Good afternoon, everyone, and welcome to the BFIRST BSSH Congenital Hand Symposium with a focus on training and outcomes in resource-limited settings. So my name is Wee Lam. I'm a consultant plastic surgeon in Edinburgh. I'm the immediate past chair of BFIRST. We're very excited to partner with our colleagues from Touching Hands, Research International, and Ganga Hospital as well. Before we begin, a couple of announcements. Your audio will be muted throughout the whole webinar. Please use the Q&A function, not the chat function, to submit your questions to our panelists. We really encourage you to send in as many questions as you can. If possible, try and keep the questions relevant to the sessions being presented so we can focus the discussion. But send in any questions anytime. This webinar is being recorded and it will be available on the BSSH and BFIRST website. We will be conducting polls during the session. We're going to allow 30 seconds per poll, so please participate and put in your answers quickly. It will make the webinars more fun. In case of any technical difficulties, if you can't hear anything or see anything, please email mr.brighton@bssh.ac.uk. Okay, so before we begin, I want to invite Jonathan Jones, who is the current chair of BSSH Overseas Committee, to come and say a few words. Jonathan, please.
Thanks very much, Wee. I'm an orthopedic and hand surgeon, and a good day, everyone. It's a chilly autumnal day in the UK, and most of you will be in warmer climates. I'd like to offer a hearty welcome to you all for part 2 of this exhilarating symposium on congenital hand surgery. Part 1 was excellent value, and I personally learnt much from it. I was impressed by the clear and honest teaching styles with great practical tips from a gifted global faculty. And it was inspiring to see delegates from over 67 countries asking questions and sharing their knowledge and experience. My sincere thanks to our host, Wee Lam, and the organising committee, and especially Emma Brighton and the admin team for their smart, innovative planning of this event. The membership of the British Society of the Surgery of the Hand comprises both orthopaedics and plastics surgeons, and is a rare example of an interface surgical society which celebrates unity in diversity. The value of an orthopedic or an orthoplastic approach to our work is a proven value, particularly in congenital hand surgery. It's a great pleasure to work with BFIRST again. As we've done on many occasions on our overseas projects, we have shared aims of empowerment, sharing of knowledge, and strengthening of the global surgical community, which is what we need in these challenging times. So the BSSH is also honoured to join with Touching Hands, Research Africa, and Ganga Hospital today, and a warm welcome to them. So I'll finish by giving you advance notice of the International Federation of Societies for Surgery of the Hand. I think I got that right, IFESH, and that meeting will be held in London on between the 6th and the 10th of June 2022, with a focus on hand surgery in lower to middle income countries. We're hopeful that by then, God willing, the pandemic will be a distant memory. So please do consider joining us in London for a post-COVID conference and a celebration of global partnership in hand surgery with plenary sessions, surgical workshops, complex case discussions, and so forth. Emma Brighton is again the point of contact for that at this time, and if anybody wants to register an interest, then please do. Finally, my thanks to all the delegates today for joining us today on a Saturday, and to your families for their forbearance and patience. I hope you have a stimulating and enjoyable time and occasion, and I'll pass you back to Wee Lam, and many thanks indeed.
Thank you very much, Jonathan. So congenital hand surgery is challenging, even in developed countries. In developing countries, there are several other unique challenges, often compounded by the late diagnosis and presentations. Wherever we have traveled, we found congenital hand surgery to be at least 20 to 25% of the workload, whether we have the expertise or not. So it is an area we need to focus on. I want to just quickly share some of the principles we found when treating and teaching congenital hand surgery overseas. One of the principles we found useful is to really focus on the common conditions and to treat this well. By doing something called a Pareto analysis, you can find out what 80% of the cases are. And in Asian countries especially, most of these are polydactyly and syndactylies. And the less common cases can probably be managed with ongoing international collaborations. Secondly, be aware of common associations. Is there a syndrome? Do I need to be aware of anesthetic risk? Do I need to conduct other investigations? Without a geneticist, this can sometimes be difficult, but it is important to know the common syndromes well. And as mentioned in part 1, this is one of the reasons we have designed an OMT app, which is free for download on the Apple App Store and Google Play Store, and hopefully this may help. Thirdly, know that despite our limitations, children adapt, and they do so remarkably well. Ironically and humbly, we have learned so much from untreated conditions in resource-limited settings that children do very, very well. It doesn't mean we don't treat congenital hand difference, but it's important to remember that a congenital hand difference is not always a problem that we have to fix. Lastly, if we are operating, we need to realize what's achievable and what's not. Not every place will have facilities for an X-fix to distract radial aplasia. Not every place will even have facilities for splinting, so we may have to improvise. So the purpose of today is not only to look at some common conditions, but also to discuss management in the resource-limited settings. And we have planned the program in such a way that we will reflect some of these principles. So we will start off with a session on congenital hand surgery around the world, and also look at the role of Wallans in children. We will then have a session on thumb duplication, and then one on thumb hyperplasia, and then we will have a whirlwind tour of different malformations, and then we will end with symbrachydactyly, both microsurgical and non-microsurgical. And then we will end with a very exciting complex case discussion where we will invite all the panelists to participate. Now, we really hope this symposium will be very useful to every one of you, and for this reason, we've lined up a very exciting panel of national and international speakers and moderators. We're very grateful to each and every one of them. Now, so we're going to begin. I want to introduce our first two moderators. Rob Baines is a consultant plastic and reconstructive surgeon in Leeds. His special interest is in adult and children's hand surgery and nerve surgery, and is part of the BFIRST team to Hanoi, Vietnam. And Shilu Shrestha is a consultant hand and reconstructive microsurgeon in Nepal. And she graduated from Nepal, and she went on to achieve a Master of Surgery in Orthopedics and a fellowship in hand and reconstructive microsurgery at the National University in Singapore. Her interest is also in congenital hand surgery. So I'll hand over the time to them now. Rob and Shilu, please.
Thank you, Wee. As we said, this first session, we will hear from two of BFIRST's international partners. And it's my pleasure to introduce the first speaker, who is Huyen Tran from Hanoi. Huyen is a plastic surgeon who has interest in not only congenital hand, but brachial plexus, microsurgery, and ear reconstruction. And she came out to visit us in Leeds on a couple of occasions. And we also had the pleasure of going out 3 times to visit her team in Hanoi. And it was really a fascinating experience. And they're a great team, doing great work. And they have a huge number of complex, not only congenital hand cases, but brachial plexus and all sorts of other conditions. And she's going to share those with us now in her talk. Over to you.
Good afternoon. I'm Dr. Huyen from Hanoi, Vietnam. I appreciate the opportunity to present to you the topic about congenital hand surgery in Vietnam. Vietnam is located in Southeast Asia. Hanoi is capital in Vietnam. In total, our country has 64 provinces and a population 96 million people. If you have a chance to visit,
we can't see your video just at the moment.
There are lots of beautiful places to visit from the north to the south.
Sorry, I hear you, and you can stop playing. I'll play for you.
The hospital is a beautiful.
Okay, I'll show your video for you. Just bear with me 1 second.
Good.
Okay. Thanks for your patience there, everyone.
Good afternoon. I'm Dr. Huyền from Hanoi, Vietnam. I appreciate the opportunity to present to you the topic about congenital hand surgery in Vietnam. Vietnam is located in Southeast Asia. Hanoi is capital in Vietnam. In total, our country has 64 provinces and a population 96 million people. If you have a chance to visit my country, there are lots of beautiful places to visit from the north to the south. Currently, my hospital is the Vietnam's University Hospital, which is in city center. The population of the city was estimated to be 10 million. The hospital was founded in 1904 as a part of Indochina Medical College. Nowadays, our hospital is the largest surgery center in Vietnam with 50 theaters, 2,000 beds. The hospital is the leading hospital for over 30 main hospitals from other provinces. My department is maxillofacial plastic and reconstructive surgery and was founded in 2007 by Dr. Ha, my boss. Now we have 15 surgeons. We performed about 4,000 main surgeries per year, for example, general plastic, face trauma, microsurgery, hand surgery, ear reconstruction, peripheral nerves, and aesthetic, etc. Hand surgery is one of the areas that is in the developing stages and we would like to further develop more. So microsurgery is very important to us. We have a lot of trauma and we have to use microsurgery to reconstruct some of this. This is a serratus flap reconstruction for extensive skin loss of the hand. Thus, we reconstructed with latissimus dorsal flap and another case of ear replantation surgery. Despite all these experiences, we still find hand surgery very challenging, especially congenital hand surgery. That's why we are very grateful to BFIRST for coming to share with us their knowledge. The first visiting of the BFIRST in Vietnam, Dr. Willem in Hanoi, came to my hospital. After that, I visited UK as a BFIRST fellow. From this visit, I became very interested in hand surgery. I visited Leeds and Edinburgh on this fellowship. After that, the Leeds team, Professor Simon K., Robert Banks, and Sarah Taplin came to Hanoi. We are so grateful to them for teaching us hand surgery. Every time they come, they saw many patients and they teach us how to examine patients and make decisions. We also operated on many patients. Professor taught and guided us from the beginning of the first patient encounter to the operating room and post-op follow-ups. And they were so patient to teach us. Our patient's family was really appreciative for the treatment they received. As you can see, they gave flowers to the professor. In 2018, I also had the opportunity to train briefly with the Professor Raja Sabati in India. We are very grateful to BFIRST and Ganga for helping us in Vietnam. In this following slides, I would like to share with you a few cases we have encountered and which we have to try to do ourselves after their teaching. This patient showed duplication thumbs bilaterally. We remove the small radial thumb and transfer the collateral ligaments. Partial osteotomy, then the thumb is stabilized using percutaneous KY across the joints. And here we have the result at the bottom. This is another patient who has a duplicated proximal phalanx and post-operation. Professor taught me the importance of getting a straight thumb, and I tried my best. And here we had a case of macrodactyly with severe deformity of the middle digit. We amputated the middle finger and debulking the index finger. And here we have a final result. Patients in Vietnam generally are understanding when we explain the best way is amputation. Another case of the macrodactyly where we debulk the index finger. And here, this patient has APERS syndrome with a classical presentation such as craniosynostosis, cleft palate, syndactyly of finger and toes. We performed surgery for craniosynostosis, palatal repair, and syndactyly release. And this patient has the right thumb hypoplasia type 3B according to blood classification. I am very grateful to Professor Simon K for teaching me politicization. This is my first politicization. Vascular malformation of the hand are lesson parallelism that we encounter frequently. Here is a venous malformation of the left hand. We used tourniquets during surgery and dissected the venous malformation, preserving branch of the median nerve and tendons. And here another example. We also performed the treatment for cleft hand and obstetric brachial plexus injury. We have progressed so much in our understanding and skills. However, hand surgery very complicated. The biggest difficulty for us is the lack of experiences and expertise in very difficult case. We also lack the experience in hand therapy training. The patients also present late. We have so many cases and we continue to learn to do the best for our patients. Therefore, the support from BFIRST are very helpful for us in improving a better treatment for our patients. It has been a wonderful journey to learn hand surgery. I would like to thank BFIRST, especially a thank to Professor Simon K, Dr. Robert Banks, and Liz team, and so many others for helping us in Vietnam. We're looking forward to seeing everyone again. Thank you.
Thank you so much, Huyen, and I want to congratulate you for your great work, and thank you so much for sharing with us. And we will take the questions at the end. So now I would like to introduce our next speaker, Kemi. Kemi is the consultant burn, hand and reconstructive surgeon at the National Orthopedic Hospital in Lagos, Nigeria, and she has been practicing since 7 years. And she has a special interest in reconstructive burn surgery and hand surgery. And she has been the BFIRST Fellow in Manchester, UK in February. So hand over to Kemi, please.
Hearty greetings from Lagos, Nigeria. It's my pleasure to share with you our experiences with congenital hand surgery. In spite of our increasing technological advancement and modernization, most Nigerians and indeed Africans still hold on firmly to certain cultural norms and beliefs, especially as it relates to pregnancy and childbirth. It does not matter whether they are rich or poor, educated or illiterate. For instance, amongst the Yoruba tribe of southwest Nigeria, it is believed that pregnant women should not venture out at certain times of the day when evil spirits are thought to roam about and may possess the unborn child, leading to severe deformities. It is also their belief that drinking local herbs and concoctions during pregnancy will ensure a safe delivery and a strong, healthy baby. About 40% of mothers presenting to our clinics admit to taking these herbal mixtures. The chemical constituents of some of these herbs have not been extensively studied. However, some ingredients like moringa seeds have been linked to fetal abortions. We get a lot of referral from the southwestern part of the country, and the institution is also the WHO Center for Treatment of Clubfoot. So we see a number of these cases. These are some of the common cases that present to our clinic. By far the commonest will be polydactyly. However, we do not get to see most of these cases in our clinics because the local midwife will have tied off a simple extra digit with a piece of sewing thread and will only get to refer such cases if the digit fails to fall off after about a week or two due to bony connection. When we see a child having more than one congenital anomaly, we will try to search on the internet for a syndrome that fits the description. Some syndromes are easy to spot due to their distinctive features like the apats. Late presentation is the rule rather than the exception with regards to some congenital anomalies. Amongst the Yoruba tribe again, it is believed that the more extra digits a child is born with, the wealthier the child will become in future. So some mothers don't consider this a problem and may not seek help to avoid tampering with the child's destiny. Sometimes a patient brings a child and we will notice similar untreated condition in them as seen on the left. The gentleman on the right only presented because he had recently developed pain in the foot. Those mothers who present with their kids early would want the surgeries done as soon as possible, and when such anomalies affect multiple digits or limbs, they ask if all the surgeries can be done in one sitting due to financial considerations, and we will counsel them on the appropriate timing and the reason for staging the surgeries. When they present with a child with polydactyly, most parents already have an idea of which digit they want removed, and with the aid of x-rays, we would usually either agree with them or in cases where we disagree, we will explain why and generally reach a consensus. For other digits in syndactyly, we release at about 9 months, while other digits will start releasing from 18 months. Sometimes we get unusual requests. For instance, this mother wanted us to preserve this bit of extra digit attached to the little finger, despite us offering to take it off at no extra cost. Our default donor site for full thickness skin graft is the groin of the child, and it usually heals quite well. We will anchor our grafts using monocryl or PDS sutures. For apart hand syndactyly, we aim to achieve a 4-digit hand, and on the foot, we will typically only release the first web space to allow the child wear flip-flops. We will immobilize in a cast for 2 weeks after a syndactyly release, and sometimes on inspection of the graft, we will find that we have lost some or all of the grafts. We have 2 options of managing this. Either we would regraft taking split thickness skin grafts from the child's thigh, or we will dress conservatively with agents such as Polymem. And the results are usually comparable at about 2 weeks. Here we use Polymem, and here we used we regrafted. For macrodactyly, we wait till they are a bit older before intervening. Offering amputations are usually met with a brick wall. Sometimes, like in this case, the mother only consented to having the middle toe removed, which is what we did. For this gentleman who presented at about 40 years of age, he only wanted us to amputate this end of his big toe, so he will no longer need to buy 2 pairs of shoes of different sizes. What we did was to open up, did some debulking, and shorten the distal phalanx, and then docked the soft tissue so that the toes were on the same level, and he was quite pleased with the result. For amniotic band syndrome, we would usually relieve using multiple Z plastics, doing half of the circumference at one sitting and the other half about 3 to 6 months later. Sometimes we go in much earlier when the child will present with limb-threatening lymph edema, like in this case, where we released at about 4 weeks of life. We have some challenging cases. Sometimes we really cannot offer much in terms of surgery, and in cases like this, we would refer to the occupational therapist to optimize the use of the hands. Other cases, we allow the child to grow and address issues that may arise. In other instances, we try to find them a good prosthesis, which are hard to come by and very expensive. This child presented with a radial club hand and was referred by the pediatric orthopedic surgeon to see if we could extend the elbow, do a soft tissue release to extend the elbow to make it more cosmetic. But observing the child, we noticed that she was quite functional with the hand, and we fear that intervening surgically may lead to some loss of this function, so we declined. This case, I believe, will have been discussed already in a previous session. The mother wanted us to remove the radial thumb of this duplicate thumb because it was ugly, it was extra long, proximally placed, and did not have a nail plate. A review of the X-ray showed that it was actually the more developed of the 2 thumbs. Watching the child use the hand, we noticed that the radial thumb was actually the more functional one, while the ulnar thumb was not moving at all. So we will take most of your suggestions and opinions in order to decide what's best to do for this child. In a nutshell, these are some of our experiences in congenital hand surgery and displayed our team of plastic surgeons in Lagos, Nigeria. Thank you for your attention.
Thank you, Kenny, for a great talk there. I think we're going to move on, leave questions till the end. But the next item on the agenda is the first poll of the day, and it relates to the next talk really, and that's around local anaesthetic procedures in children. So the question is, in what age groups would you be comfortable doing procedures under local anaesthetic? And I think you've got 30 seconds to give us an answer to that. Sheila, do you do much local anaesthetic in your practice?
Sorry?
Do you use local anaesthetic much in your practice?
Yes, I do use Wallen, but I don't use it for the pediatrics so far yet.
Yeah, okay. So there we've got an answer, and I guess the majority of people use local anaesthetic for older children. but we'll see in the next talk what's possible.
Now I would like to have this pleasure of introducing Professor Don Noland, who is a world-renowned plastic surgeon as the father of wall-in surgery, which is the short form of wide awake local anesthesia, no tourniquet surgery. He is the current BSSH Director of Outreach and International Relations, and he has previously been the president of Canadian Society for Surgery of Hand, and American Association for Hand Surgery, and the Canadian Society of Plastic Surgeons. He has published over 100 papers and 30 book chapters, and we had a privilege of learning from him personally 2 years back in Nepal. So I would like to hand over to Dr. Don Noland.
Thank you so much, Dr. Shastra. Nice to see you. Talk about wide-awake hand surgery in children so that you can afford to do surgery in developing countries. There is a wide-awake hand surgery book with a whole chapter on pediatrics, how to do kids, and a website. I'm not making any money on either, but they are good sources of information. So we're just going to let him start. And we're going to be real quiet here, because what happens is they kind of get into that trance where they sort of fall asleep after a few sucks. I pinch the skin as I put the needle in, and the baby hardly flinches. There he is. I just put the needle in. I've massaged before I put it in, and I keep massaging and pinching gently. Mom, you're doing great. So is he. I can tell you that the pain is now going away from personal experience. He's not hurting anymore. I'm just holding his foot so he doesn't run away. That's bugging him more than the pain. The pain is not bothering him at this point. You're seeing actual injection time. This is a short 30 gauge needle with a 3 cc syringe. You don't move the needle at all. Just get the needle underneath the skin and inject very slowly. And then after the baby has finished eating and is asleep, you nip off the accessory digits in mother's hands. In this case, I actually had to cut it out with a scalpel and remove the extra little toe. And put in absorbable stitches, which you can do with field sterility with the child in mother's arms quite easily. We try to have the children come in hungry so that they're interested in eating, and then they fall into the post-eating trance so that we can do the surgery. So I finished injecting the other foot, and 2 weeks before this, I did the child's both hands, which also had fifth finger nubbins. And I'm now going to ask Mom how much the needle bothered the child for the two hands 2 weeks before. Putting the needle in.
No, he didn't even flinch.
He didn't even flinch? No. And we did both hands, right?
Yeah.
Yeah, and both times he was good, right?
Yep.
Yeah, he flinched a little bit here, but when we did the hands, he didn't. I'll tell you why, because it's a lot easier to hold a hand than a foot.
Yeah.
Feet are a lot stronger.
Yeah.
This is a video by Dr. Chao Chen from Jinan, China, in a 4-year-old who had a flexor tendon repair. And the child came back for a tenolysis on this occasion, was numbed in a very similar way to what I'm going to show you. The child was looking at a video on a cell phone with the mom. The mom was in the operating room with the child. And then they let the drapes down so that the child could see the finger flex. And then the child was able to flex the fingers quite nicely. And Dr. Chao Chen does this routinely, as I do in my practice in Canada. So what we're going to do today is some real magic. Do you believe in magic? You do? Really? I kind of don't. I think magic is usually a trick. You know, usually there's something that people do that's a trick. And the trick to do the magic is, in order for me to stop that thing from popping like it's popping, I'm going to put some magic medicine underneath the skin. And this medicine really is magic, because once it's in there, I'm actually able to cut the skin and it doesn't hurt at all. And if that's not magic, I don't know what is. So it really is kind of like magic. But the only problem with the magic medicine is, in order to get it in there, I really have to use a really tiny, tiny needle. And it hardly hurts at all. You'll see. You'll be kind of amazed. Do you have a brother?
I have 2 older brothers and a sister.
And a sister. Did any one of them ever take an elastic and go thwack on your skin and annoy you? Yeah. That's about how much that hurts. It's not terrible, just a little bit. But the main rule about putting in the magic medicine is the don't move rule. Because when I put that really little tiny needle in for that short little sting, if you go and pull your hand away, the needle comes out and I got to stick it back in, so it hurts 2 times. If you don't move, it hurts 1 time. Now you can move a little bit, that's all right. But I'm going to hold your hand and help you so that we try not to move. Is that okay? And the other thing I'm going to do is I'm going to pinch your skin 3 times. I'm going to go 1, 2, 3, just like that. And the 3rd time I'm going to kind of hold it a little bit like that. And when I count to 2, when I say 2, you take a nice deep breath. And then when I say 3, I'm going to say don't move. You try not to move and you'll see there's hardly anything to it. Does that work for you? Think we're good?
Yeah.
Yeah, I think so too. Okay, let's go do it. Is it, sweetheart?
Is it hurting at all?
No.
Excellent.
Of course not. So, many children fall asleep during the procedure, which is exactly what she did. After we repaired the profundus tendon, we tested the range of motion and found that she had excellent flexion and extension. When we repaired superficialis, we found that her active range of motion was actually downgraded. So, I want you to tell me, it's 3 months ago we fixed your finger, right? Yeah. Can you tell me how sore it was when we put the numbing medicine in there?
Just hurt when you first put it in.
Just when I first put it in. And after that it didn't hurt at all?
No.
No. Did you mind being awake while I did your surgery?
No.
No. Did you mind moving your hand? Remember we asked you to look at it. You had to look at it a couple of times. What did that feel like?
You.
But you kind of got used to it though, eh? Yeah. Do you remember falling asleep during the surgery?
Yeah.
Yeah, you were kind of snoring, actually.
No.
Yes, she was. I remember. Yes, you were. All right, great. Thank you. So it was 7 years ago that we fixed your finger. Can you go ahead and make a fist and straighten out? Right. So do you remember?
I remember you making me look at it, and I couldn't look at it, so I had to look away.
Do you remember if the needle hurt terrible when we put it in?
No.
No, it wasn't too bad.
No.
Did you mind being awake?
Not really.
No. Okay, great. Thanks. Now, the thing, though, is that to put the magic medicine in your thumb, the only way to do that is to put a little needle right there, but it's not going to hurt hardly at all, especially if you hold nice and still. Do you think you can hold nice and still for me? All right. That sounds good. Well, I think you're pretty good for 4. Okay, so do you remember what we're going to do now?
Yeah.
What are we going to do? Tell me what we're going to do.
We're going to put a little needle in here.
Yep.
And then we're going to put a Band-Aid on after.
Okay, that sounds good. I like that. We're going to put a little needle in there. And what are you going to do when I put the little needle in?
Take it out.
Yeah, you're not going to move. You're going to hold still, okay? While I get the magic medicine in, okay?
Yeah.
It's going to sting a wee bit, but you're going to hold still, okay?
Okay.
Okay. All right, here we go. I'm going to hold your hand, I'm going to make it easy for you.
Well, it would hurt on the top.
Yeah, just a little bit. Yep. You don't need to look. You can
Well,
look away.
What my dad says is always take a deep breath and hold it for a little bit until it doesn't hurt.
That's a great idea.
Yeah.
So at the count of 3, I'll tell you when to take a deep breath, okay? Okay, you ready? Okay. 1, 2, take a deep breath right now. Oh, what a good girl you are. Oh, what a good girl. It's almost finished hurting. Can you please tell me when it's not hurting at all anymore?
Not hurting anymore.
Oh, isn't that great? You were so good. Now, I'm not finished putting the magic medicine in, so we need to stay here for just another little minute. Is that okay?
Yeah.
It's not hurting at all, is it? No. Isn't that great? And you're going to see with this magic medicine that all of the pain is going to be all gone when I take that out. It's not going to hurt one little bit. This is Dr. Steve Kohler in New York, plating both bones in bilateral fractures in a 12-year-old. This is at the peak of COVID times. If you move the pain or if you move the bones around and it doesn't hurt at all, that's a sign that the anesthesia is adequate. And it does bleed a little bit without a tourniquet, but you get used to that. A little blood never killed a surgeon. You have to inject the other side of the cortex. Otherwise, they feel the screw coming out the distal end. That's an important thing to do. It's basically important that you blow up the whole forearm. Just inject enough local anesthesia wherever you're going to be operating. And in this case, because he's used 70 milliliters, you can use 0.5% with 1 in 200,000 epinephrine, and that's going to be totally effective. The operating rooms in his hospital were filled with COVID patients, and so they did this in an outpatient procedure room with field sterility, because that was the only place they could operate in their hospital at peak COVID times. There's the post-operative x-ray and result at 4 weeks. So if you're still hurting people with local anesthesia injection, please stop. I hurt people for the first 20 years of my practice before I learned how not to. So it's never too late to stop hurting people. If you go into YouTube and you search Lalonde Ictec local anesthesia, you're going to see a full lecture on how not to hurt people with local anesthesia. All of the 13 points in this slide are covered in that YouTube lecture. Using smaller needles, slow down, use buffered local anesthesia, don't inject in the dermis, always use sensory noise, always put in more than not enough local, never advance sharp needle tips in places that are not numb, never reinsert needles in skin that's not numb, always inject too much volume instead of not enough volume, always get feedback from patients, use filler cannulas for big areas, and always inject from proximal to distal so you get the larger nerves at the beginning. The most important rule about the freezing is the don't move rule. If you pull back, then the needle comes out. I have to stick it in 2 times. If you don't move, it hurts just 1 time, okay? So try not to move. And at the count of 3, I'm going to put the needle in, so don't move, okay? 1, 2, 3.
That's cool. I feel it, but it's not.
Sorry for the little sting there.
Nothing at all. I'm surprised. Compared to what I've been putting through, like with this.
So you were kind of petrified of the needle, right?
You have no idea.
Right, because you hate needles, right?
Can't stand.
Right. How much did this one hurt?
Out of like 1 to 10?
Yeah.
0.2.
Okay.
Like 0.2, not even 1.
Okay, good.
Like really 0. I barely even felt it.
Good. So at the count of 3, just try not to move, okay? You're going to feel 3 little pinches, okay? 1, 2, 3. Very good. Beautiful. So at the count of 3, try not to move. At the count of 2, take a nice deep breath. Can you do that? Is that okay?
Yep.
Okay, good. 1, deep breath. Don't move. Good. How sore was that?
Didn't feel good.
And this is the 3 cc syringe with a 30 gauge half-inch needle, which is one of my favorite things to get started for local anesthesia so that the whole process doesn't hurt. Thank you.
Professor Lond for talk. I think we've got time for a few questions, and there's some come up on the chat. I think mainly for Professor Lalonde. The one question around the safety of adrenaline in local anaesthetic, and also about how do you control bleeding when you're not using a tourniquet?
Right. So the first question about epinephrine in the finger, you know, we used to believe with a myth that epinephrine kills fingers. That myth was born before I was. The myth was born before 1950. And now there is all kinds of good, solid evidence with thousands and thousands of patients that epinephrine does not kill fingers. And there is an antidote in phentolamine, which people almost never use. So epinephrine, adrenaline is safe in the finger. And the second question is, what about the bleeding during surgery? You know, we're all surgeons. We've also been totally indoctrinated in that there should be 0 bleeding during hand surgery. But you know what? We can all survive seeing a few red cells in the field. I mean, most of us have trained in other parts of the body where we don't put a tourniquet, the head, for example, and we do just fine. And so a little bleeding never killed anybody. I do like a tourniquet if I'm doing a vascular malformation, or if I have a sarcoma in a forearm and I really need to see, or if I'm doing a giant cell tumor in a finger, I'll put a little tourniquet on the finger. But most of the time, I'm just fine with a little bit of bleeding, and we don't need cautery for most of these. And so what it means is we can move them out of the operating room, where we do most of our hand surgery in Canada, in my practice and in many other cities, is outside the operating room, which is very affordable for folks with limited resources. I think one of the most important things about Wallant is that you can take surgery out of the operating room and patients don't have to pay the anesthetist fees. And also, surgery is safer without sedation. When we talk about safe surgery, we're really talking about safe sedation. And the safest sedation is no sedation. And so if you take sedation out of the equation, safety is much better. So it's cheaper and safer for people with limited resources. Thank you.
And I think we've got a question on complication rates, asking whether do you think there's any difference with local anaesthetic in terms of, you know, wound dehiscence, infection, graft loss, things like that?
Yeah, I don't think there's any difference, really. If there's any difference, it may actually be less, because especially with things like bleeding, there's no tourniquet letdown, so post-operative bleeding tends to be less. And also intraoperative education, teaching patients during the surgery to keep their hand up higher than their heart, no walking around with their hand dangling down, and having the surgeon tell them that during the surgery. They sit up at the end of the case, they put their hand higher than their heart. Their risk of post-operative bleeding and post-operative complications is less because we educate them on how to avoid things like infection and how to avoid things like post-operative bleeding. And that part helps a lot.
Thank you. Well, I have a question for Kemi, actually. I was interested to see your slide on the local superstitions around childbirth and deformities. And of course, I guess to some extent we have that kind of thing all over the world. Certainly in the UK, we see mothers who have an element of guilt when they have a baby who's born with a congenital hand difference. But I just wanted to ask, and perhaps to Huen as well, how do you deal with these problems when they arise and you have a mother in front of you with a child with a congenital hand problem and the guilt and things associated with that? What kind of things do you do?
Yes, thank you. What we usually will do when we have a mother, usually they are distressed, they feel it's their fault. So we try to put them through some bit of embryology, that as at the time the child is being formed, they are not even aware they are pregnant, but that some factors have been linked. So we try to educate them to use less of the local herbs. So we use that opportunity to do that and then try to tell them that it's not their fault. It's just the way the child, usually they will come in with mother-in-laws and, you know, with pressure always falling on the woman. So we counsel both them and their mother-in-law as to how it's not really their fault. It's something that occurred while the child was being formed. And in most instances that they can be corrected. And in instances where we think they can't be corrected, we counsel, for instance, the child that had both arms and feet absent. We try to show them videos of someone that had similar anomaly, had grown up to adulthood, and is actually very popular because he could swim, he could drive. So we try to motivate them with that.
Okay, thanks for that. And Huen, is it much of a problem in Vietnam as well?
You're muted, Tran. Your microphone's muted, Huen.
Sorry.
Hi.
Yes, it's the same situation in Vietnam.
Okay. Well, I think we're probably a bit overdue to move on to the next part of the session. So I'll hand back to Wee now to move on to...
Great. I think Dawn has to leave very soon. So Dawn, thank you very much. I think there's still quite a few questions on wildland. Maybe you can answer some of this on the Q&A chat, okay? Thanks Rob and Shilu and all the speakers for the first session. We're going to move on to our next session on thumb duplication. I want to introduce our two chairpersons. So Jill Smith is a consultant plastic surgeon working in Great Ormond Street Hospital in London and also the Chelsea and Westminster Hospital. Jill sits on the BSSH Council, is the current chair of the Training Interface Group in Hand Surgery, and we're very happy to have her here to help us chair this session. Our other chair is Kemi, whom we've just heard from. Kemi is a consultant plastic surgeon at the National Orthopedic Hospital in Lagos, Nigeria. She was a BFIRST fellow in burns and hand surgery this year. So I'll hand over to you, Jill and Kemi.
Thank you. Well, we has already commented how polydactyly is one of the commonest things that the BFIRST people see when they go to other countries and is one of the commonest problems around the world. And of course, the thumb is such a vital part of our function. It's really important that when we are operating on it, we get it right. And so the next session is talking about thumb duplication. We're not particularly going to be talking about associated factors, but you may remember from before, the more limbs that are affected with an abnormality, the more likely it's syndromic. And you'll remember that from the last webinar. And do remember that though it's rare, you can get Fanconi's anemia with thumb polydactyly. And it's worth looking at Wee's OMT app to help you where you haven't got geneticists to help you out on things. But just as a general thing, Fanconi's, remember the things we can easily see: small head circumference, cafe au lait spots. Now, I'm going to come on to introduce the first speaker, which is Drew Fleming. Drew now works as a consultant plastic surgeon in St George's Hospital and has done so for many years. His training included time in South Africa, in Great Ormond Street Hospital. He was there before me in London, so I had a hard act to follow. And with David Evans in the hand clinic. But he originally originates from Zimbabwe, and he goes back there to teach frequently. On a webinar, you don't see the size of Drew. But when Raja ran the BFIRST, we went to the Taj Mahal together. And we had lots of Indians coming up wanting to take a picture of him because he was a head, shoulders, and a bit more taller than any of the local people. And I think they thought he was some amazing giant. But I can tell you he's a very gentle giant, and he's very, very good with the children. You'd never think somebody so tall would not be imposing, but he's got a lovely way about him. And I'm sure he's going to be able to tell us some good things about tips and tricks about how to manage thumb duplication. Thank you, Drew.
Thanks, Jill, for that very kind introduction. I hope you can... We're sharing the screen there.
How tall are you, Drew?
I'm only 6'6", Jill. So there we go. So Jill, thank you very much, and thank you, we as well. It was my association with BFIRST has been only latterly, but as Jill says, I've been out to Zimbabwe many times, my old home country, on missions to help train some of my colleagues out there, and it was great fun having we along, in fact, with the very first BFIRST mission a few years ago with some of our other colleagues from Manchester. So I think some of my colleagues, Tran and Kemi, have already shown us the sort of common thumb duplications which we do see in the third world, and certainly also here in the UK, and I'm sure everywhere else you practice around the world. And it's a very interesting subject. I'm sure most of you are aware of the Vassal classification, which is a radiological one, and we understand that it was actually devised by a medical student back in the day. I pay tribute here to both Adrian Fatt and to Simon Kay's book, The Growing Hand, with his colleagues Amit Gupta and Shekhar, for some of the diagrams in this talk. If you look at the diagram at the top right, you'll see that this goes through from Vassal 1 through to 7. The commonest ones I've ringed there, and certainly Vassal 4 is the commonest one of all. 2, the next most common, and then triphalangism. And you'll see that I've put a plus there because really just about everything else is dumped into the category of a 7. And I've put a few little slides here, clinical slides, to show you a Vassal 2 duplication, an asymmetric 4, and a couple of examples of 7s. And you'll see sometimes it can just be a mere little nubbin, and this is a more well-formed accessory thumb there. In Simon's book, you'll see that there's just a little bit more of a representation of that. I think the important point, the important tip to take away from this all is this is very much a radiological classification, and it doesn't take account of the soft tissue complexities, which I'll try and allude to as we're going along. I think some of the important things you need to discuss with the parents when you see these children with radial duplications is that in the vast majority they are unilateral and non-syndromic. As Jill's mentioned, Fanconi anemia is one of the associations, and I personally do now get any thumb duplication to go and see the geneticists and let them do the appropriate blood tests. And you'll see there's a reference at the bottom of the slide. Again, Simon's name featuring prominently. The one thing that they undoubtedly are is familial in many circumstances, and you'll see on the picture on the right here, a family with triphalangeal thumbs. But in fact, interestingly, around us at St. George's in southwest London, we have quite a large Korean community, and for whatever reason, there's a strong familial incidence of thumb duplication in that community. I think the other important thing to, in your initial discussions with the parents, is the whole concept of cosmesis versus function. And this obviously runs through congenital hand surgery from top to bottom. And generally, the more distal the duplication is, the more cosmetic, and I put it in inverted commas because obviously it's not that pleasing to look at, but the more cosmetic the deformity can be considered, but the more proximal you really do start getting into functional problems. I also quite like this concept of explaining to the parents that from an embryological point of view, these thumbs have often been one thumb which is split into two at some stage of embryogenesis, and that especially where you choose the ulnar thumb in the more asymmetric ones, they tend to be a little bit smaller than the opposite or contralateral normal thumb. Also, once you get to the more proximal duplications, that the reconstruction, often the IAP joint or in fact the MP joint, may not move terribly well, and especially if you use various Bilhart-Cloquet type of reconstructions, which I'll come on to. So therefore, I also think it's quite important to stress to the family that as the child grows, despite your terribly accurate osteotomies, etc., there may be subsequent deviations and the need for subsequent surgery. So this is just one of my little girls. In fact, her mum is a pediatric anaesthetist, and Sophia has bilateral vessel type 4 duplications. And you see how well she's actually holding those balls despite the fact that she's got these duplications. And that's her post-operatively about 10 days. Just for your purposes, the sort of things to run through your mind before you even start out on this type of surgery is you're really trying to create one stable, straight thumb of an adequate size, preferably much the same size as the opposite thumb, although that's not critical. But also the shape is important, and if possible, some range of movement. Most of these thumb duplications have a relatively normal CMC joint, and obviously that's vital for most thumb movement. The IPJ and MCP joint less important. I also say it's quite important to try and not get a scar through the nail bed if you possibly can, because this inevitably leads to ridging of the nail with subsequent growth, which can be of functional importance. And for the plastic surgeons out there, this is really the original, one of the original spare part type of surgeries, which you mustn't, when in your planning, you just mustn't throw anything away until you very carefully thought what you might like to keep for your reconstructed thumb from anything before you throw it away. I think the other important concept is that of the symmetric versus the asymmetric duplication. The symmetric ones tend to be more distal, and I'll show you what I tend to do with these, which is a modified Bilhart-Cloquet type procedure. And more proximal duplications tend to be asymmetric. And in these, as you'll see at the bottom here, the ulnar element tends to be the more dominant one and the one you need to retain. But that then means that you will certainly need in your planning to consider osteotomies, collateral ligament, and various tendon reconstructions or repositionings. And I've just, again, put the reference, one of the references for Bilhart-Cloquet procedure down the bottom there. So this, just pay attention to this diagram as I chat through this slide. And in terms of, and again, that's from Adrian Flatt's book. In terms of timing, I think ideally you want to try and get to these kids by the age of 12 months or even earlier. And I certainly consider these any time after the age of 6 months, because at that time, the bones are really easy to cut just with a simple blade, either a 15 blade or a beaver blade. And you can easily stitch bits of bone back together with a 5/0 PDS or with small wires if you need to. And I think the abiding principle of this surgery, especially with these asymmetric or more proximal ones, is you want to try and do everything in one operation to obviate the need for further surgeries as the child grows. So if you look here, you want to try and excise asymmetric joint surfaces, and you'll see an osteotomy through there. You want to do straightening osteotomies to whatever remnants of the bone you've got left. You want to realign and share tendons, both on the flexor and extensor aspect. And on the flexor aspect, you may want to reconsider, you may want to centralize the flexor pollicis longus by reconstructing the pulley if need be. Of crucial importance when you're retaining the ulnar element is to think about the APB tendon insertion, which would invariably be into the radial element, which you're going to discard. So not only do you have to retain that APB tendon of insertion, but also the radial collateral ligament of the MP joint, which you'll need to reinsert as part of your reconstruction. Then you want to hold the whole assembly with the thinnest KY, which you think will do the job. And I would tend to say at 0.6 or 0.7. And as I said before, try and avoid your split nail bed. Again, this is from Simon's book and just gives you an indication of that. What I would draw your attention to is try and use Z incisions as far as possible so you don't get a straight line down the back of the finger especially, but also volally, because these tend to, as you know, with plastic surgery principles, will tend to prevent full extension and flexion later in life. And it just shows you there rejoining the two tendons to give a single tendon. Again, this is a slightly asymmetric one with a wedge osteotomy having been done. Most of that element, the radial element, being discarded, but again, using both the collateral ligament and the extensor there to combine those to form a single tendon. And this just happens to be a child I saw yesterday in clinic. That's the original X-ray. That's my little diagram from my operation sheet. And that's the little one done in clinic yesterday. So this is just an example of a vessel 2 duplication, so quite a symmetric distal duplication. And these are my markings for the modified Bilhart-Cloquet, and I'll explain what I mean by that in the next slide. And that's the sort of result I would hope to get. Again, you can see that's fairly soon post-operatively. So this is the original Bilhart-Cloquet procedure, which you'll see was a simple wedge excision of all structures within the duplication. The modified Bilhart-Cloquet really is allowing us to keep one of the nail complexes there, discarding the other one. And then you'll see the joined up duplication has just the one nail complex, and the bones would be just joined up together as for that one there. As you go more proximally, then you get into the situation where is this duplication symmetric? Is it convergent? Is it divergent? And this is an older child who I've done a modified Bilhart-Cloquet. You see I've gone against my own rules and used a largely straight line there. These days I would definitely use a Z. And I've also gone against my own rules and split the nail. But this is to try and give me a decent sized thumb, which I think we've achieved here. And that's, so you can go against your own rules just to get the better sized thumb. The problem with these Bilhart-Cloquet and these type of duplications is that you're joining these joints in some fashion or other, so they often get very little range of movement at those joints. And that just tries to explain that. So with the Vassal 4, if it's very asymmetric, again, you'd keep the ulnar, discard the radial, do your osteotomies to try and get one straight thumb. With the convergent or divergent, some sort of modified Bilhart-Cloquet to get the bones aligned into a reasonable straight thumb. And this just shows you, again, myself doing an asymmetric vessel. It's really a 7, I suppose, because the radial element in this particular one is a triphalangeal element. But in terms of the osteotomies, I think you can see there's one through that segment of duplicated metacarpal head there. Then secondly, I've done another osteotomy through the metacarpal to realign the whole ulnar element to give us a straight looking thumb at the end of the procedure. And remember, this is just the x-rays. There's no soft tissue reconstruction, which is obviously vital to this reconstruction. Getting to the end here, and I'm probably encroaching on Raj's territory a little bit, but this is just a little kid who pitched up in clinic again yesterday. What I did want to point out to you clearly here, this is a thumb metacarpal. Don't forget the thumb epiphysis is proximal, a finger epiphysis is distal, and you can just see this here. So this is a relatively normal thumb here, but you've got a triphalangeal thumb coming off it. And I just wanted to chat to you about one particular point with regard to triphalangeal thumbs. Sorry, just going back one there. Again, you see that that's definitely a thumb metacarpal. Just be quite wary when you see a hand like this with a very distal takeoff and a nail which is not necessarily in pronation like a normal thumbnail, that you just want to make sure you're not dealing with a 5-fingered hand, which needs a rather different approach to a thumb duplication. Right, I'm going to leave it there because I think Roger probably has something a lot more to say about triphalangeal thumb and various oddities. So this is just, and finally, that's just a reference. which gives you a very good overview of the whole subject if you want to go and look at this in any detail. Right, thanks. Jill.
Thank you. Thank you very much, Drew, for that wonderful presentation. And please note their questions, and we'll try to take them at the end of the presentation. I think I will be contacting Drew later on for the last part of my presentation. Or maybe after listening to Mr. Raja, maybe I'll have a clearer view on what to do to that patient. So I think it's time for the second poll of the session. Emma, can we have the poll? Okay. In this poll, please note that you can pick more than one answer. And it goes thus: in term duplication, what factors will help you determine which of the duplicate term to keep or remove? The parent's choice, the size of the digit, X-ray findings, active movement of the thumb, or a misshapen thumb. Please, you have 30 seconds to vote. You can choose more than one answer.
More than one answer, so we can.
Yeah, so we can see majority picked. Well, it's actually spread across size of the digit, X-ray findings, and active movements of the thumb. So I think by the time we listen to Professor Ryder's presentation, we'll be clearer on this topic. It's my pleasure to introduce to you the world-renowned Professor Raja Sabapathy. He is the chairman of the Department of Plastic Surgery, Hand and Reconstructive Surgery, and Burns at the world-renowned Ganga Hospital, Coimbatore, India. He is the past president of the Indian Hand Society, the Indian Society for Reconstructive Microsurgery, and the Brachial Plexus Group. He is also the incoming president of the Asia Pacific Society for the Surgery of the Hand, and he is on the executive committee of the BSSH, which is the International Federation of Societies for Surgery of the Hand. His main interests are in hand surgery and reconstructive surgery. And I'm looking forward to your presentation, sir. Please go ahead.
Thank you so much for the opportunity. And we asked me to talk about dealing with complications and rare presentations. I think Drew has given an extraordinarily good overview as to what we should do. And this can apply for anything. The best way to deal with complications is to prevent them from happening. And that's exactly the way where we are also planned. So I'll try to explain with examples as to how the potential complications could be avoided. So the poll was very good. It said, which one will you take off, or which one will you keep? Most of the time you will find, I think we need to take all. I think you need to take radiology, you need to take the size of the size, whether it's ulnar or radial. But most of the time we have found in our experience, 95% of the times now we have kept the ulnar side member. I think very rarely have we kept the radial side, because in our pinch and strength, I think we need the IP joint and the MCP joint. And naturally occurring ligaments are much more better than however much we create. So that's the reason most of the times it will be the ulnar one we should read. And the next point, I'm so happy Drew saw the same words. I think this is very, very true as far as duplication of thumb is concerned. And because it might look that we have a lot of skin, you'll find that you don't have much of skin later. So never throw away things unless you're sure you don't need them. And I keep every bit of the skin and discard them only after I finish. So for example, in this patient, so we need to take this away. This part of it we'll be taking away. So you see that the X-ray, how it is there, and then we are going to get it there. And we are going to take this part away. So the amount of skin that I take on the dorsum is only this. And when I put an arrow here, this again is important. When you take the skin, you must take the germinal matrix is here. So don't take it off here. Suppose if you place it back somewhere, you can't be so awkward to get some nail here. So just go across beyond the germinal matrix, and then that's the way you go. And then And this is where you connect here. So that's the reason I get back to it as fast as possible, as short as possible here. So that's the way now we do that. And you see the segment that you're taking off, it is just bare, it's naked. So there's so much of skin that's there. And after that, you do the bony work. This side now we straighten up, we pull it up, and then reconstruct it because it is so much deviated. And we put in a pin, and then that's the type of result now that you could get. So what you said, as Drew said, is very important. You need to get a stable thumb. I think that is what is very important. So now this is all a rare complication. I think not rare presentations. See here, you see a child. I think this sort of things can happen in many developing countries. These sort of quixotic anomalies are very common. I think it's extremely difficult to do. So here you find this is okay, yeah. But then the other part of it is you find it's bent, it's thin. I think it's thin, you can. So you need to do a lot of work over here. If you ask me what is that one thing that you need to really do well, I think it's skin. I think you need a good amount of skin. Even if you want to do any type of work, you need to do skin. And this is almost like a floating thumb, so it is attached by only a very small pedicle. So the question is, what do you do with this? Because you find if you take the X-ray, it has got no metacarpal. It's not connected anywhere. So the only thing that you could use is the skin, if possible bone. I think the bone is quite okay, yeah, but then you need skin. So what have we done here? So what we have done is we have opened up on the ulnar side, we opened up. We have filleted at this flap first. And then what do we do with this small bridge? So I don't take any chances, even if it takes a one bit of extra surgery under local anesthesia, do that. This is just linked up with a small pedicle. I think it's just a small. So don't try to do too much into show skills, delivering it there, tunneling it and all that. Just put it over there and then drape it around. I think we just drape it down so that now you got a good thumb. I think you got a good amount of skin that you get. And afterwards, after 3 weeks later, you come back and then you divide this skin bridge and then so you get it back. So now we have got a lot of things to work. You can put in a bone graft, we can put in straighten it, you can do that. So as far as possible, get the skin inside. I think that's what. Now, we had asked me in the comments box in the program, is around toplasty. I think putting one thing over the other. I think this again is a good example. Here again is a tough case, really. See, that's the ulnar component and that's the radial component. The radial component has got the metacarpal. Whereas the ulnar component, it doesn't have a metacarpal. It is again, it's floating. But if you see the size of the fingers, the ulnar is bigger. So ulnar is, looks better and all that. This is, very thin. It's tapering. So it's not. It has got a good nail, and this doesn't have a good nail. So this would be better. So what we are thinking is that why not we put this on top of this, take this off. Try to put this in over this, take this off. I think that's what now we are trying to do. It's technically challenging, but then it's nice to do that. So that's the same thing which is pulled over. So what we do is that we plan that this goes. And we plan that this one comes over here. So I think that's the plan. So how does it over? So you need to open up on this side. So open it up so that the pedicle gets in over there. So that's a part of the pedicle. This is the filleted one. This is staying back, and which this has to go onto this, and it's ready. So off there. But once it goes over there, I think you repair all the tendons and all that. This goes with the nerve supply. The nerve and the blood cell, the nerve supply is almost like an island flap. You get it over there. You repair the tendons, and we have got abundance of skin. I never take the skin. And after that, refashion the skin, and you'll get a thumb which is over there. So this is the on top plastic that we get, and that's the result which we have got. If you see these children, Drew again said they will require some more surgeries. It's quite important. So you might have to talk to them before because, and if you see the palm, there is a hyperplasia of the thenar muscles. So these children, and now the thumb looks good. Thumb is of good size. It could be powerful. It has got adequate bones. So what it requires, you need to empower it. You need to empower it. You can do it by APV appearanceplasty. You can do this. You can take this by an appearanceplasty. I think that could be quite possible. And getting a smooth nail, I think that's a very difficult job. As Drew said, I also try to avoid as far as possible trying to get the nails. So we have very few cases where we do this because most of the times we try to get a nail fold and not a nail. So the key things that I have found are quite useful is when you have to get the two nail beds to, the key stitch is this. The key stitch is the one what you get into the germinal matrix at this edge. So that has to be done with the thinnest of the absorbable sutures. So I take a buried stitch. I think don't put a stitch over here because even that gives a problem. I take a buried stitch over there and then get it up, and then we go. So if you have to get this, that means it should really not be very strong. I think you need to divide a lot of the structures in between. So that's what is important. See, for example, here, say here is a patient with that's a sharing of the nail. So if you have to create this, you do this, you need a nail fold. So this is very important. If you don't have a nail fold, the finger doesn't look like a nice finger. So you need to get a nail fold. So, but then the whole of it is the nail, and then you get a germinal matrix, a continuous layer of germinal matrix. So you need to have some part. The nail fold is only here. This has to come here. So that means you need to have a good amount of excision that you have. So that's the X-ray radiology, and that's the volar side. So we need to get we are trying to maintain as much as possible of this, and that little part of it has to go in over there. So you're in the center part, all that of it you divide, you design, and then get it together. And you see that's the nail now. 2 years post-op, that's what we have got. Seeing this, I find that you could have even a little bit lesser part of it I could have taken, but the parents are very happy. It has come out well. The important thing is you must not have this line is okay, but then if you have a groove, I think if it goes around or the nail does not develop in between the two segments, then it looks ugly. If it looks like this, I think that's fine. And you must not allow syndicate to develop between the nail fold and the sutures that you put. I think that's very important. Suppose if you develop the common cause for because you have a suture in the nail bed and you've got a suture in the nail fold, so they can adhere. I think if they get adherent, that means you can't get a nail. So after doing this, you keep the small bit of the nail and you keep it as a spacer. I think you should keep it as a spacer. If you keep it as a spacer, then it's fine. I think that's what now we do. And that's the same child where done. That's the volar side, that's the dorsal side result. I think that's the way we get. So you must get stable joints. I think no matter what, you need to get stable joint, and you must get powerful thumb. I think that has to be there. So the important things, the Drew also said here again, I always keep more skin. I think keep a lot of skin, and if you take this and then if you put skin and you transfer all the muscle, still if this is bent like this, they don't like it. I think it doesn't look good. So what you need to do, you also need to do something on the other side. So what are the things that we do is you'll find that extensors divide, and you must use all the tendon power. So you need to take this and you need to radial segment. Now you need to rebalance it so that you attach it preferentially on the other side. It's not in the midline. Say whichever side you want to do, you do that. And you go to the other side, small incision, and then divide the ligament, the collateral ligament, a little bit, so that it gets up. And anyway, you're going to immobilize them for about 4 weeks. I put on a wire, so it'll all heal well. So you need to use the extensor to balance it. And on the ulnar component, the radial component, you have the abductor insertion. So that again has to be taken along with a good amount of bone. You take it up a good amount of bone and then slap it over there. And I think you slap it over the other side, put in a good amount of stitches, and now I divided the amount of skin that is required, and then place it up. So then it looks good. So then you will look good. So this is the way you should be able to have it. So you need to have adequate skin, you need adequate movement, you need to have the straight joint. That comes up because not only we have to divide the ligament, But in spite of it looking good, if you take an X-ray, it look bad. I think in the X-ray, it really look bad. So, but then what really makes it look better is the amount of soft tissue padding that you put, that makes it look better. So point number 5, we all think that when duplication comes, the joint is more difficult. We need to have more technique and all that. But the thing I found that a couple of times where I got caught is in doing these type of surgery where you think it's child's play. It's just attached to the bone, no problem. You just shave it off, take it up, and do. So what really happens is the worst thing that can happen is this. Okay, it has happened on 2 occasions. Once after that, I burned my fingers. I've always been very careful. So you can't, because it not only happens because you sometimes you don't shave the correct amount of bone, and you also keep a little bit of more soft tissue. I think when you have a finger like this, the way you put an incision and take, so you need to see at the end of surgery, it has to look good. If it is looking thing, if you think it's a little bigger, it's got a little bit of dog ear, a little bit, you think it will take some time, it will heal, it never heals. I think time doesn't make compromise the mistakes that you do on the table. So if it's not all right on the table, it's not all right. It's never going to be all right. I think when you leave the table, it has to be all right. Okay, that's what. So I am very careful when you do this. So having learned that experience, so when I do such cases, I'm very careful. So you take off the bone, and not only take off, I really take off nicely. And in addition to that, you will have bones will have the nerves will be there, and you need to really separate the nerves and see that it's not common ones, and then bipolar coagulate it and push them out. Otherwise, you could have a neuroma at the end. So ideally, what you should have result is you need to have results like this where there's no bulge, so that there's no bulge to make them think that you have had it. So same thing again. So you have a bone like this, you take it off and attach it such a way that it looks good. At the end of surgery, it has to look good. If it looks good, it looks good. So now we come to triphalangeal thumb. So this is one of the tough cases to do because if you see the triphalangeal thumb, this phalanx could be a rectangular one, or it could be a delta phalanx. If you really look it closely, if you just expand it and see, it would be a delta phalanx. The other problem that they have is that they may be bent like this. I think they're all bent like this. So what you really require, as Drew said, you need to have a straight thumb. Okay, you need to have a straight thumb. You need to have a thumb which is adequate in size, and you need to have a thumb which is sensate. And the pulp must be facing the other fingers. I think these are the guidelines. So how do we do this? I think what we have to do is you have got an extra finger, and in most of these, the most important thing is the incision, the access incision. Sometimes you might have more skin, but then because you put a incision that's wrong, that means you're not able to close it. You find there's a curved incision, and then you put in a straight incision, and then after you bend it, it opens up like a diamond, and then you can't close. So in cases where it is bent, either you must take an S incision or an incision like this. So after you straighten it, this will come in, and then you will be able to close. So that's what now we are doing. So we've done this, and what we have done in this case is correct the contraction. You excise the small delta phalanx, and we arthrodesis the IP joint. I think this child was what 6. I think it's better to do this arthrodesis the IP joint. Not that you really take off you don't shave too much. You just shave off the cartilage and then put in a pin, and then you retain it without infection for about 4 to 6 weeks. They're all stiff. I think this will give stability, form, and enhance function. The same child whom we have done, I think there's this. See the child, there's the triphalangeal thumb. See, we have done we have both put in a small wire and a K wire. I think that's what when she's writing well. She's got a power to write. She's doing well. Before now, she was not using the thumb to write. Okay, and she's using the hand. So I think that's the way we should treat the triphalangeal thumb. The triphalangeal thumb, the key is incision, access. Access is the key. So this again I used rapid. It's not a thumb, but this again the same principles you could apply. I think this again is a difficult problem. If you ask them what it is, he says he is not bothered about this, but then he is bothered about this because a lot of people keep asking them. I asked him, what do you want? I want a one finger. So here you find the same problem. Now you got a share nail. So share nail, when they come, I think it should make you think. I think you have to do it very nicely and correctly. So what do you think? I have decided to keep one part of it and not this one. You see the incision, the incision goes just proximal to the germinal matrix, so no way we get nail bed remnant, nail bed cyst and all that. You do this, and you take off all the rest of the things, so you take it off, and you straighten it out and then fix it. And you straighten it out and fix it, and that's the way you get a nail fold. So here, if you are not taking a nail bed and a fold, the best that you can get is this. So it doesn't look like a nail fold, and it doesn't really look like a nail fold, but then you can easily pass it off. Now, so it's not like this. It cannot be like this, but then that's the best that you could achieve. And preoperatively, when you flexed it, you get this, and then when you flex it, you get this, and that's the sort of a nail fold that you could get in the post-op. Now, the other difficult thing that has been an uncommon thing, a rare presentation, is a five-finger hand. And Drew again pointed this out. I think it's a very nicely, he told, differentiating between the thumb and the fingers. Thumb metacarpal has got the epiphysis down. I think for all the ledges is like rest of the fingers, and you got a epiphysis over it. The metacarpal has got a distal epiphysis, and you got 3 fingers. So in the five-finger hands we have seen, what I look at it is how are they oriented. So you find in this hand, on the left side, it has really come out well. So this boy was on the left side was using it well, but whereas here there is not enough of a gap, so it looks like 5 fingers are all in the same plane. So for on the one side, what we are going to do, we are going to polishization. I just follow the same thing what has been written in Simon Case and book Growing Hand, because I was also with Louis Shecker, and he's a master in polishization. Just do the same way as it is in the book, Growing Hand, and you get a polishization. So this makes it better. Okay, then for five-finger hands, the treatment for five-finger hand is polishization. So we need to get the thumb in a different plane to that of the hand. I think that's the message we need to get it, because no matter whatever you do, I think unless you polyshize, it doesn't look good. So then the other rare presentation to finish off is the ulnar dimalia, where you got so many fingers, and you really need to choose which finger to choose. To call something as a ulnar dimalia, you need to have 2 ulnars, not one radius and multiple fingers. Then it's called as supernumerary fingers. If you call it as a mirror hand, I think you need to have so many fingers, but also you need to have 2 ulnars. If you can't have a ulnar and a radius with multiple fingers, it's not mirror hand. So here, then you need to really choose whichever finger is the best, and try to polyshize that. It's an extremely rare condition. So I decided to use this polyshize this finger and take this off. So I'm sure we can't use this skin, but then try to get as much of skin as possible. Never throw the skin away. So you see a lot of flaps are lying on. And when I take it, it's only a skeleton, it's naked. The bone should be naked. I think that's what I tell our guys. And you take this off, you take a flap, and then you polyshize, you take up it's a standard polish. You take the bone off and fix it up. And as it is told, as Louis Shecker used to do, I don't know, many times don't put a pin, but I put a lot of nice sutures to anchor it in the right position of turning over. And then use the available skin to put it on. This child, they sent this picture a few days after just before, it was about 6 months after we did it. The child starts using the thumb as a normal hand. One advantage of this ulnar dimalia is in the fingers that you excise, they also have got some flexor tendons. So you could use it for any type of movement that you would like. I think, So these are the rare presentations. So my 20 minutes is over. So the take-home points is that you should plan well. The most important point is, Drew said, children can grow up with no disability without operation in most cases. And though the hand looks very different, first aim is not to downgrade function. And you must achieve primary wound healing in all of them. And most of them will need soft tissue reinforcement from the exercise segment. Don't throw it away, don't cut it off. The joints, you must make the joints stable. So if you ask me one single point as to what I think when I operate, I just think at the end of it, the thumb must look like a thumb. I don't care about the bones and all that. No. At the end of it, when you finish the surgery, the thumb must look like a thumb. If the thumb looks like a thumb, I think everything inside is quite all right. Thank you so much.
Thank you, Raja, and thank you both. You've gone way beyond the normal thumb hyperplasia, Raja, on that last one, but both of you have dealt with some quite complex problems. For the audience, we're going to move on fairly quickly. Please remember to ask questions and answers. Now, I just have one quick question for both of those two speakers, and please just answer as a rough percentage. What percentage of the thumb duplications do you see? Do you do a simple excision and using the excision of the radial digit and readjustment of the ulnar digit, not a modified Bill-Hochler, not an on-top plasty, not anything wild and wonderful, but more standard procedure? What percentage, Drew, first?
Definitely the majority, Jill.
Okay.
Yeah.
And Raja?
I think 90%.
Okay, just wanted to make that point that they've given us some lovely lectures, but most of them are the more straightforward, but don't forget to do it right. And now I'll pass on to Wee just to introduce the next panel.
Thank you very much to Jill and Kemi for sharing that and all the speakers. We're going to move on to a very difficult problem and challenging problem, thumb hyperplasia, continuing the theme of the thumb. Our two chairpersons are Drew Fleming and Nicholas Lubega. So Drew, as you have heard just now, he's a consultant at St. George's in London, from Zimbabwe originally, and he still goes there regularly. Very pleased to have Nicholas Lubega with us. He is originally from Uganda, but currently working in Malawi. And his interest is in reconstructive surgery in children. He has been involved in organizing teaching in Malawi with AO Alliance and BSSH for the last 10 years. We're going to go straight to Scott without the poll. So I'll pass it over to Drew and Nicholas, please. Thank you.
Thanks, Wee, and it's my honor to introduce you to Scott. I had the latter privilege of listening to Scott talk in Bath a couple of years ago when he came down to speak to BSSH, and we shared a few beverages, I think, together later. So Scott is, again, a unique person in our sort of grouping here, in that not only is he a preeminent professor of orthopedic surgery at the Shriners Hospital in Philadelphia, but what he did in his time as president of the ASSH was somewhat, perhaps before even we started getting going with BFIRST in this country, was realizing that we needed to give something back, and founded Touching Hands during his year as president of ASSH, starting initially with a mission to Haiti, but now traveling to many parts of the world. Scott is obviously a hugely talented and very popular member of our hand surgery world, and it gives me great pleasure to invite him to talk to you about thumb hyperplasia this afternoon, a topic which I know all of us find at times frustrating and difficult, but also fascinating. So over to you, Scott, and thanks very much.
Thank you very much, Drew. I am going to introduce thumb hyperplasia, principles of management, and then Simon's going to talk about pulsation. So my talk is mainly on the reconstruction of the hypoplastic thumb, but not the pulsation that Simon will discuss. The take-home points is that for thumb reconstruction, you require a stable base, but that's not always easy to determine. You would think it would be easy, but it's not always straightforward. X-rays are unreliable because the CMC joint doesn't ossify until somewhere between 4 to 7 years. Advanced imaging studies such as ultrasound or MRI would be helpful, although MRI require anesthesia. And most importantly, I think it's the child with a stable thumb will incorporate their thumb into activity. The child with an unstable thumb will ignore their thumb for the most part. And I don't think there's any hurry to reconstruct the thumb, so I think time is in your favor. And then pulsation, like Simon is going to speak about, is for the unstable or the absent CMC joint. Now, this is your standard classification, groups 1 through 5, with 5 being absent and 1 being just slightly small. In fact, type 1 often presents late in adolescence when kids know, or adolescents note that something's wrong with their thumb. There's always some red herring of trauma, but it's just some mild hypoplasia of the thumb. Usually does not require reconstruction. My focus is talking about type 2 and type 3A, where the intrinsic thenar muscles are absent, there's narrowing of the web space, and there's often ulnar ligament insufficiency or laxity. Before I talk about the concept of recreating opposition, I think everyone needs to understand that opposition is extremely complicated. It's a combination of palmar abduction, flexion of the thumb, and pronation. In fact, measuring opposition really requires motion capture analysis to assess the true volume that the thumb can move in space. And we've all seen people with advanced carpal tunnel, like you see on the right side, that clearly has no thenar eminence except for the deep thenar muscles and has pretty good motion and function, but really lacks opposition. So reconstruction for type 2 and 3A, you have to address all the elements of the hypoplasia. So the web is narrowed, as we spoke about on the first webinar. There's thenar absence, which we'll talk about today, and there's often MCP joint instability. Now, with reference to what we need to address, we spoke about the thenar eminence deficiency, as you can see here in the pickups. Here's your ulnar ligament instability, and here's your narrow web space. Now be careful because the thumb can go into valgus a fair amount because of the UCL insufficiency. So the web space may not look as narrow as it actually is, but for the most part it is narrow and needs to be addressed during the reconstruction. So the narrow first web space is the first thing that we address. Most of the time in hypoplastic thumbs, a 4-flap Z-plasty suffices. You need to understand that it's not just skin, you need to release the fascia, and you need to identify and protect the Princeps pollicis artery. For those that are more advanced, like we spoke about last time, we do use the dorsal Ghani flap. It's become our workhorse flap for those thumb index web spaces that are markedly narrow. With reference to opposition donor muscles, this is a frequently asked question. You do have multiple options. You can use your FDS, you can use your abductor digiti minimi, you can use your EIP, you can also use your extensor carpi ulnaris. I gave a debate a few years ago against Terry Light and spoke about the pros and cons of FDS versus abductor digiti minimi. And this is my slide. Do you really think that abductor digiti minimi depicted on the left can stand a chance versus the FDS depicted on the right? And our go-to has become the FDS transfer. Why? If you go way back in hand surgery, and most of us on this call are familiar with Paul Brand, the ultimate missionary. If you look at fiber length, and if you look at mass fraction, which is generation of strength, the FDS tendon is much stronger and is much longer fiber length when compared to the abductor digiti minimi. So we have almost exclusively gone to the FDS unless the patient does not have an FDS or an independent FDS from the FTP. So I'd like to run through an example. This is Andreka, a 9-year-old with a type 2 thumb hypoplasia. Here are the x-rays that show well-developed CMC joint. As you can see, the left thumb is a little bit smaller than the right thumb just by radiographic appearance, but the CMC joint is well-formed and clinically very stable. The technique involves an FDS harvest, and I'll show you a little bit of a video in a few moments. You pull it through the carpal tunnel, and we do the old Bonnell loop. We take half of the FCU and make a loop, just like you see here. Because remember, for the opposition transfer to work, and work means palmar abduction, flexion, and pronation, the point of the pulley needs to come from the pisiform. So regardless of your donor tendon, you need to somehow get to the pisiform and then bring your tendon transfer from the pisiform to the thumb. Here is the FDS being passed through the pisiform, I'm sorry, through the FCU loop at the pisiform, and then a subcutaneous tunnel to the thumb. And then for the ligament reconstruction, we prefer to pass the tendon directly through the bone to the metacarpal head using a cannulated drill system. It's then pulled down along the ulnar metacarpal ligament, ulnar metacarpal joint, and then the ligament is reconstructed in an extra-articular fashion. The joint is then pinned, and here you see the 4-flap Z-plasty. So here's a video. It's a little bit of a shorter video, but the entire video is on our website entitled littlearms.org. So this is a different patient, but you can clearly see that there's absent the thenar muscles. There's narrowing of the web space. Your incisions can vary. We continue to modify our incisions, but we're pretty happy with our 4-5 Z-plasty, as you see here. The skin is elevated. The Princess pollicis artery must be identified. And the fascia above and below the adductor is released to make sure the thumb index web space is of adequate size. We tend to close as you go. That's the expression. So we'll close the index side of the Z-plasty, leaving the radial side open for the MCP joint ligament reconstruction. We close with absorbable sutures. Here's the FDS harvested, and it's isolated both at the base of the ring finger and in the palm. You don't need a lot of length, so just releasing the A1 pulley is adequate length. The tendon is pulled through the carpal canal. Here's the SCU loop that we spoke about. You just take a strip a couple centimeters and then bring it back to itself. To make sure the loop does not get too narrow, we put a freer into the limb and then we'll suture it down to the remaining FCU. Once we're happy with the FCU loop, we pull the FDS through and then over to the thumb. Do not forget to put it through the loop. That would be bad because then your vector would be disturbed. And then once we pull it over to the thumb, we're placing our drill hole in the metacarpal head. We're going to grab the tendon from the ulnar side. We're going to pull it through. And then we're going to pull it back down to reconstruct the ulnar ligament. So this tendon gives adequate length. We routinely pin it. And then we set our tension in our opposition transfer now by the particular fashion, like I said. And there's your repair. And then the arm is closed. We typically leave these pins in for about 3 or 4 weeks, and then we remove and then we resume therapy. So there's your nice ligament reconstruction, and we'll close that last Z-plasty. Here's your whoops, let me go back 1 second, I'm sorry. This is a long-term outcome, I'll show you here, of a child that underwent FDS opposition transfer. Note adequate palmar abduction, flexion across the palm, and pronation. And you can see them pinching here. And the most important activity that we do currently is to text. So it's the left thumb here. And you can see it lines up parallel to the other thumb for texting. And it works pretty well. And this is why this has become our preferred donor tendon for opposition transfer. And the last point is that if you do it right, it'll last for a long time. And kids are resilient. And that's all I have. Thank you very much.
Yeah, I'm just going to, there are a few questions which have come through. So Scott, just on the first question, are there any tips for deciding if the CMC joint is stable or not? And what is your most important factor in just making that decision?
So like Simon showed, a lot of times when the x-ray, if the metacarpal tapers down to a cone, it's not going to be stable. So those I think you can act upon early. In those that you're unsure, I think time. I think just like Simon said, we used to do pollizations much earlier than we do them now. You know, one of the Peter Carter sayings is the hand doubles in the first 2 years of life and then doesn't double again till you're done growing. So I actually do pollizations later than I used to do them. I do them closer to 1.5 years or 2 years. We've just found the surgery easier. I don't know what else to say. It's easier, it's more straightforward. You can get a better sense of the rotation. The vessels are bigger. So now we wait a little bit longer. And if I'm unclear, that usually means the parent is unclear and there's no harm in waiting.
Great.
And just to say, Drew, if you want to check the stability of an MCP joint, of a CMC joint, you can just grasp the metacarpal and move it around. And the ones that are unstable are very demonstrably unstable. The other thing about pollicization, I mean, I'm quite old now. And the thing about pollicization I've seen change is that the enthusiasm for doing them in radial dysplasia is lessened and lessened in my life. And I'm very cautious about that now. If you haven't got a well-corrected wrist, because even when you do correct the wrist, that wrist that's been at 90 degrees, the index finger has the least excursion and is always the least flexible, least useful digit. And sometimes now I won't correct the wrist because they're so good with their ulnar advanced prehension pattern that meets the world first. I don't think you're ever going to convert them into a competent radial prehension pattern that competes with that. That might be a little out there, but that's what I think.
Just a more practical question. Would you start your pulsization dissection volarly or dorsally?
I always start dorsally. So I always start dorsally. I can't think of a reason not to. I start dorsally. The breath holding moment is finding your veins. Once you've found a vein in each flap, it's a riot after that. So you need to find those veins, get them isolated, separate them. And so I start dorsally at the PIP joint. And as you work down, dividing the transverse veins between the PIP and the tip of your composite flap, you will identify where those veins are in the apices of the flaps. And you also find the dorsal digital nerves very easily. And once you've lifted that up,
yeah, so let me just be a
sorry,
contrarian.
there's one point I just wanted to say again, Scott. There's one point that I teach every trainee, and no trainee really gets at first, is that when you lift and tent the skin and put your blunt scissors in, you come into the superficial fascial plane, which is the plane you wish to find the flaps, the veins and the nerves in.
Yeah.
That's it. I'll shut up.
So Drew, just to be a little bit of contrarian, so we actually start volar, which is interesting. Actually, I think Buck Gromko has influenced everybody over in Europe, as we and I spoke about. We start volar because it's fairly straightforward to find the arteries. And if you're a little bit over-exsanguinated, just a smidge, then by the time you get to the back, the veins are filled. That's just a different way to think about it. I do think the veins have to be done sharply and you have to find them quickly. And if you pull the skin up, you'll find the dorsal veins. But we do start volar.
Nick, any comments from Malawi and your experience?
Yes. So Simon has just talked about radial club hand. What we find here is that when you tell parents about the point that you've just raised, that the child is used to having the hand like that, what you find that they would rather have the hand more in a functional position, more in a straight position, than basically they will have to convince you to put the hand more in a straight position and not leave it the way it is. But the good thing is that most of those children actually do have a thumb. It's quite rare that we find that the thumb is actually not there for most of the children's radial club hand here.
Okay.
Well, I think good, Simon, you go first.
Well, I think, I mean, that strikes right at the philosophy of children's hand surgery, which is that you're treating the child and the future adult, but you can't isolate them from the family. So everything you do has consequences that radiate out from that focus to the future adult. I'd much rather spend a long time explaining myself in several interviews to the family than doing an operation I wasn't convinced was in the child's interest. You say the wrist straight is a more functional position, but it isn't always in these children actually, because you deny them the ulnar prehension approach that is the only one that's competent in some of these children. So it might be the more anatomically pleasing, but it's not always the more functional.
And I think function is the most important. So actually we have to spend quite a lot of time trying to explain to the parents that what we are looking at is the function. And sometimes they do accept that, yes, please go ahead.
Yeah, Nicholas, and I agree with that. But of course, this is beyond the scope of this, but the appearance of the hand is part of its function, just as it is in the face. The appearance of the face is part of the function of the face. So it's a difficult issue, I agree.
And Drew, just one quick comment. I think if you're seeing a lot of radial deficiencies with a thumb, you need to be concerned they don't have thrombocytopenia absent radius, because those are the ones that have thumbs, right?
Correct.
Point.
One point, if I can make, Scott, I like your concept of a stepwise approach which you teach your fellows. Anything I would ask both of you is, I know there are varying opinions of this. Does anyone still shorten the flexor and extensors, or do you just leave them to get back to their normal lengths with growth?
I don't shorten either the flexor or extensors, but Buck Ramco shorten the extensors.
I always shorten the extensors. I always
Buck
shorten the
Ramco.
extensors.
Yeah.
So I always shorten the extensors individually. One becomes the long and the short extensor. In the flexors, I don't shorten them, and I kind of don't understand why I don't. But if I were going to shorten them, I'd shorten them above the wrist.
Okay, cool.
But I don't, and I never have, and they work. So I guess maybe I don't need to shorten the extensors either, but I always have and they work. So you kind of become a victim of your own experience, really.
Yeah, I don't think David Evans ever shortened either of them, just by the way. I think Wee's lurking there, and I suspect that's the end of our session. So thank you very much, Scott and Simon, for sharing your immense experience with thumb hyperplasia and policization. Cheers.
Thank you. We will come back to that during the complex case discussions as well. We're going to take a 3 to 5 minute break now, just for everybody to have a bit of water and just a 3 to 5 minute break. And then we'll come back and we'll look at various malformations. Okay? Over to you, Emma. Okay, we're gonna start. We're coming to the last part of our webinar. We're gonna take a tour of various malformations. Each of these malformations really deserve, a much longer time, but this is the time we have. I'm going to hand over to my chairpersons now, Lorenzo and Tanvir. So Lorenzo Garagani is a consultant hand surgeon at the Guy's and St. Thomas's Hospital in London. He has a very broad adult and pediatric hand and wrist practice. He's the current president of BFIRST, and he sits on the International Relations Committee and International Traveling Fellows Committee of the BSSH, and he travels to Myanmar regularly to treat children's hand surgery. Tanvir Ahmad is from Bangladesh. He now works in the Sheikh Hasina National Institute of Burn and Plastic Surgery in Dhaka. He is the secretary of the Society of Plastic Surgeons of Bangladesh, as well as an editor of the Bangladesh Society for Surgery at Hand, and he was BFIRST Fellow in 2014. So I'll hand over to you now, Lorenzo and Tanvir. Thank you.
Thanks so much. I would like to thank BFIRST and BSSH for this kind invitation, for allowing me to co-chair this session with Dr. Hamad, and also to introduce hand surgeons who not only are world-renowned experts in their field, but also we need to remember there are people who have also a big heart and the mission that is that to treat children and train surgeons in all corners of the world. One of these surgeons who I've already introduced previously is Professor Kozin, who may I remind everyone that not only is an eminent surgeon, but he has really fulfilled this mission of training and helping children with hand differences through the Touching Hand project. Scott, I would like you to start with your first talk, and please share your experience with us on cleft hand. Thank you.
Thanks very much, Lorenzo. Can you see my slides?
Yes.
Okay, perfect. So we asked me to talk about cleft hand, principles of management of cleft hand. And this is actually a new talk for me, because what I thought we would focus on is what should and what should not be done, which is not always an easy decision, as we spoke before, myself and Simon. Now, there are a few take-home points that clearly function trumps form, and it's hard sometimes when you talk to parents to realize that the child's hand may be functioning better as is and left alone compared to changing it with surgery. And as my friend Peter Carter also says, you want to do surgery to make it more than different. It's the 2-4 rule. You want to do something to the patient for the patient. So I think with cleft hand, you need to choose surgical candidates carefully, because the surgery is fairly challenging. You need to address the first web space, you need to deal with the cleft, and you need to deal with any associated syndactyly. Adrian Fido, I had the wonderful opportunity to meet on multiple occasions. This is me when I still had hair back in 2002 at the Hand Society meeting when we were chairing the Residents and Fellows meeting. And remember what Adrian Fido used to say for cleft hand is that it's a functional triumph, but really is a social disaster. And a lot of time is spent with these kids and their families dealing with the social element, especially if it's a spontaneous mutation. If it's inheritable through the family, then it's usually more accepted and more easy to deal with. With reference to cleft hand and cleft feet, the literature is very confusing. It goes by a bunch of different names: split hand, ectrodactyly, claw hand, which is just a horrible term. And in the LMT classification that we spoke about earlier, it is a malformation. With reference to genetics, there are multiple subtypes and genes that have been isolated. It tends to come through an autosomal dominance inheritance, as you see in these two children. But notice in these kids, what's important is different phenotypes, right? So just because it's the same gene, the same genotype, does not mean it leads to the same phenotype. And Jill spoke about this a lot on our first webinar, and it's such an important point to discuss with families, and genetic counseling is helpful. And then a lot of the patients we see are new mutations. They just spontaneously mutate, and they can have lower limb involvement. And this slide is fantastic. This just shows how much the phenotype can vary. It can be a monodactylous hand, it can be a simple cleft, it can be combined in bizarre bony abnormalities. But the typical shape is a V-shaped cleft, as you see here, which has been clearly discriminated from your symbrachydactyly, or what was previously called your U-shaped hand. The bony anatomy is often bizarre, and the digits are conjoined, which really complicates surgical management. And this has a large influence on those children where you're going to operate, on those children you're not going to operate. So like I said before, it's a progression of the suppression or the malformation. And it can be just a cleft in the middle, and then it moves to the sides, ends up with a monodactylous hand like you see here. Typically, the last digit to go is the ulnar digit. If there are nubbins, that's not going to be a cleft hand, that's going to be symbrachydactyly. And it's often bilateral and can affect the feet. So here's what I thought we would do. We would talk about what should not be done. So this is a child that does not warrant surgery. So if you look, the x-ray mirrors the clinical. So obviously the x-rays on the right and the hands on the left, but the x-rays are similar. So if you look carefully at the thumb is hypoplastic, like we spoke about, and the thumb is connected to a relatively well-formed index finger. In this particular case, those two digits will function better versus trying to close that cleft and bring the skin from the cleft over to the thumb index web space. So there are a fair amount of kids that we see that we don't necessarily reconstruct their cleft hands. And it's really the concept that function trumps form. Now, go look at this. Comes in yesterday into our office. Now, this is interesting, right? So this is a child, Maverick, a 5-year-old. It's affecting both hands in a very weird or atypical presentation, but we're going to focus on his left hand. So his left hand, if you look at the x-rays, the ulnar digit is well formed. The index isn't badly formed, and the thumb is fairly well formed. So it's extremely tempting to reconstruct this hand by closing the cleft and moving skin over to between the thumb and index. But Maverick is 5, and this is his function from yesterday. So let me show this video. He goes by Maverick. Here's his left hand that we're talking about. So you notice his thumb and index are combined. And look at that wonderful web space. And this just emphasizes what Flat used to say. It is truly a functional triumph. It's really a social problem. But watch how he uses the car on the floor. Right? And you can see that his thumb and index are functioning together. And then here's Mr. Potato Head. And this nose of Mr. Potato is really stuck in there. And yet Maverick is pulling super hard to make sure he's moving the thumb. And there's his prehension. And he's 5. So we opted yesterday not to operate on Maverick. We felt that he was pretty good where he was. He was already 5 years of age, and we could make him different, but we're unlikely to make him better. Now, in contrast, who should we operate on? This is Isaac. This is a 16-month-old child. Here's his picture of his hand here. And here again, just like we did before, here's the picture of his hand and the x-ray. And what you see in Isaac's hand, there's a well-formed thumb, there's a well-formed index finger, there's a big cleft, and there's his hand. And in this case, at 16 months old, it's a different animal. And we can really make his hand look better. Like Simon mentioned, it's part of the function, and we can make it work better. Now, we tend to prefer a Snow-Littler procedure. Now, I use that term a little bit loosely because I think it has to be tailored to the child. So not every operation has the exact same incisions or the exact same reconstruction. Some of it will vary with reference to the narrowness or the wideness of the cleft, and some will vary as to the amount of syndactyly between the thumb and index finger. So this entire video is shown on our website, again, entitled littlearms.org. I'm going to show you some clinical pictures. So here is the narrowed thumb index web space. And like we said for thumb hypoplasia, don't be fooled. This doesn't look as narrow, but it is narrow and needs to be addressed. If you don't open up the thumb index web space and you simply close the cleft, the child will widen the cleft by continuing to place objects between the long finger and the ring finger. So you have to open up that web space and make that web space their preferred prehension, meaning when they pick up a can, they don't try and stuff it between their index and ring finger. They place it between their thumb and their index finger. It's extremely important. This is your standard Snow-Littler design. So it's a flap using the skin from the cleft that's going to be transposed over to the first web space. This flap starts out as a random flap, but a lot of times you can pick up a vessel volar Lee, and then it becomes an axial flap, and that's a much better flap and less likely to undergo epidermolysis. And then on the side of the ring finger, you see what's called a Barsky flap, which is a small triangular flap to reconstruct the commissure between the index finger and the ring finger. Here's the volar incision. So you can see the index is fairly free, just like a pulsation. It's a fairly narrow bridge if it ends up being a random flap, but in kids, it's probably okay. We start on the dorsal side and we elevate the flap looking for a volar vessel as we come to the volar side. Because again, that changes this flap from a random flap to an axial flap. Here's your flap being elevated. You then have to address the thumb index web space, and it's going to be narrowed. So there's this thickened fascia. You have to identify the princess pollicis, which is seen under the forceps on the right. You have to make a decision as to whether or not you're going to ligate the radial digital artery to the index finger. That really depends upon the rest of the vascularity of the index finger and how narrow the space is. And then you tend to do something to the bone. So if we have a remnant of a long metacarpal, we'll transpose the index metacarpal over to the long. If we don't have a remnant, then we typically do a wedge osteotomy, bringing the index over to the ring finger. Be careful not to malrotate the finger. We're not huge advocates of trying to reconstruct the intermetacarpal ligament. We'd rather reconstruct the bony alignment, because when you pull the fingers together for intermetacarpal ligament reconstruction, you're prone to have some form of malrotation. And then this is a pin with, now you can see the index aligned with the ring finger. Make sure there's no scissoring. And then the flap is brought over. There's a single pin to hold the fracture fixation together with the osteotomy until it heals. And here he heals. Now, remember, when you bring that flap over, do not debulk it too much. If it's big and bulky and it survives, you can always debulk it later. But just like Raj showed earlier today, it's better to have a bulky flap and come back later than to have a dead flap. Here's short-term follow-up for Isaac. So you can see there's adequate thumb index web space. So when he picks up the cell phone, he prefers prehension between the thumb and the index finger and not between the index and the ring. And here he is as long-term follow-up. Here's a good adequate web space. Here's his thumb in a good position. And here's his prehension for opposition. And there's his grip formation. And pretty much that's a home run out of the park. Now, something new I thought we would just discuss quickly in a few closing moments. Abdul Ghani, you heard me talk about the Ghani dorsal flap. He has also described a technique where it's a bipedical flap. So it's like a snow littler. I'll show you a couple pictures. But what you do, you don't elevate the flap. You take the bipedical flap and you push the index finger underneath. So here's an example. I hope this is the skin incision. So notice there's no detachment of this flap. There's a flap of dorsal and volar that's bipedical. The skin is incised. I'm not going to go through the entire procedure, but the entire video is available. Right? What's really cool about it is once you've gotten the index mobilized and ready to go, what you're going to do is pass it beneath this bipedical flap, and you have to remove the bone in between. So this is the incisions, and we're going to move the bone in between. But you notice the flap is left in situ. Then after you free up the finger, the index finger here, so that's the base of the long finger being removed. What you do, this is the cool part of the operation. You kind of just stuff it under, and then that flap that was in between the cleft then becomes your thumb index web space. So it's an interesting modification. I do think this operation's harder than the snow littler, and I do think you have to be careful not to torque the vessels, but that's a fairly impressive blood supply and fairly impressive flap. And remember, and this is the thing that I just stuck this in after Simon was talking, you know, kids are amazing, kids are adapting, and kids can do all sorts of wonderful things. If we just give them the positive reinforcements and we give them adequate support, both emotionally and surgically. Thank you very much.
Thank you. Thank you, Scott, for your another very excellent presentation. And our next talk shall be on the amniotic band syndrome. Before that, we are going to, we would like to introduce our next poll. Emma. Yeah. Here is the poll. What is your preference for amniotic band release? Option 1, that is 1 stage whole circumference without Z+T. Second option is 1 stage whole circumference with Z+T. And third option is 2 stages, 1 side at a time. There is the stage procedure. And last option is nothing. I tend not to release the amniotic band. Please choose your options from here. Okay, so as usual, the poll result is most of the surgeons used to do the stage procedure one side at a time.
We will discuss it later on at the end of the session. I will now introduce the next speaker, Dr. Alexander Kempfen, who is a plastic and reconstructive surgeon in Basel, in Switzerland. Alex is the clinical lead of both the hand surgery unit at the University Hospital and also of the upper extremity surgery team at the University Children's Hospital in Basel. He has a keen subspecialist interest in pediatric hands, and he has been a fellow at Great Ormond Street Hospital in London. Alex has also traveled to Sri Lanka to teach congenital hand surgery with the BFIRST team. So Alex, please show us your presentation. Thank you.
Hi, my name is Alexander Kempfen. I'm a consultant hand and plastic surgeon specializing in pediatric upper extremity surgery in Basel, Switzerland. I was the hand fellow at Great Ormond Street Hospital in 2013 and 14, and until COVID-19, regularly on charity visits to Sri Lanka in Lady Ridgway Hospital, and have a new cooperation with Solomon Islands since this year. My talk will discuss several aspects of treatment for children suffering from radial longitudinal dysplasia with a global perspective. Radial longitudinal dysplasia affects around 1 in 6,000 to 1 in 8,000 births, probably due to comorbidity. The perinatal mortality is around 30,000, and the deformity is classified by skeletal completeness according to Bain. Hyperplasia of the thumb has a very varying degree. The soft tissue anatomy varies to a much greater extent. The cause of radial longitudinal dysplasia often remains unclear. Associated syndromic malformations include cardiac, renal, vertebral, and blood disorders. The most common ones are the Wachtel or Vater association, the Coney's anemia, thrombocytopenia, absent radius, and Holter arm syndrome are the most frequent, which is the most frequent of the hand-heart syndromes. Especially TAR syndrome with low platelets and Fanconi's anemia with potential aplastic anemia should be remembered, as if not recognized on time can have fatal consequences. If you want to climb the Matterhorn, your goal is clear. You want a safe journey to the top and back. You therefore need to make a plan considering the weather and your physical condition. Training in mountaineering is essential. In radial dysplasia, it similarly starts with setting a clear treatment goal, which can be very different from one country to another or from one family or patient to another. We all agree that a normal hand is not achievable for these patients. How do we balance motion, stability, length, finger motion? Which of those is important? How do we set our goals? In this respect, radial longitudinal dysplasia is a remaining unsolved problem in congenital hand surgery. Today, our treatment should be based on patient-reported outcomes and their desires. To help, we can use this SMART acronym from economical sciences to help us. According to the majority of literature and our long-term review of 30 patients treated at Great Ormond Street Hospital 20 years ago, the main goal for patients is wrist correction. Finger motion, although terribly impaired, seems less problematic. My treatment protocol therefore includes stretching and splinting of the wrist from birth. Sometimes splinting is not feasible for some families, then stretching is encouraged. As this is often not sufficient to keep the wrist in line with the ulna, we try to overcome the remaining soft tissue tension. The overall goal is an angulation below 30 to 45 degrees, which is the normal radial range of wrist deviation, and further angulation is perceived as disfigurement. If you live in a corner of the world where circumstances allow soft tissue distraction safely over at least 2 to 3 months, then I advocate this as the next step of treatment. Remember that complications like infections and pin breakage happen in up to 40% during this period. So if you cannot guarantee a close monitoring, alternatives might be a soft tissue release and a local, for example, a bilobed flap. In floppy cases, a wrist stabilization without preceding distraction is an option. If the deformity is rigid, then this might though end with a short carpus and impaired growth of the already short ulna. There is no clear evidence advocating one stabilizing wrist procedure over others to achieve the goal of wrist correction. If available, soft tissue distraction can help you with decision-making which technique to choose, as it gives you an idea on the quality of the dorsoradial muscle mass, which is the key soft tissue disfigurement in these patients. Wrist enhancement can be achieved by a tendon transfer only in mild cases, as you can see on the right picture. In short type 2 dysplasia, an additional lengthening of the radius is advised. This can be done acutely if under 1 to 2 centimeters is required and can be repeated, or by gradual transport of the short radius against the ulna if you can ensure monitoring of the patients. In type 3 and 4, no adequate joint is found, and the surgeon needs to create one to keep the hand in front of the forearm. Depending on the tightness of the deformity and if there was a preceding distraction, different options are available. If distraction preceded rapidly, then there is not much contractible but very elastic muscle. If it is slow, there will be only dysplastic scarred fascia. These patients will profit from a centralization procedure, which ultimately leads to a functional fusion of the wrist. Centralization includes a notch in the carpus to stabilize the hand on the end of the ulna and leads to stiffness, but achieves strength. Radial to ulnar tendon transfer is often impossible, as there aren't any recognizable tendons or muscles to transfer. This procedure often leads to severe shortening of the carpus if no distraction is performed beforehand, and there is a high risk of further impairing the ulnar growth. If you find, on the contrast, a good muscle mass intraoperatively and the carpus is pushed easily to the end of the ulna, you might choose a radialization procedure or a reconstruction with a free tissue transfer to create a wrist-like joint. Radialization balances the egg-like carpus on a thin ulna with a tendon transfer of the dorsoradial muscle mass to the ulnar side of the carpus. It can have excellent results with up to 60 to 80 degrees of controllable and stable range of motion if the transferred muscle mass is of sufficient contractible quality. These patient muscles distract at a normal pace, around 1 millimeter per day, but usually you need to slow down around the end of the second month due to diminishing range of finger motion or pain. Radialization had a high recurrence rate until its indication was restricted to good dorsal-radial muscle mass quality. Without preceding distraction, this procedure is only feasible in mild or very elastic cases. If performed without a good muscle, recurrence is programmed, so be careful when you decide for this option. The microsurgically demanding reconstruction of a radial buttress of the wrist by free metatarsophalangeal joint transfer, according to Simo-Wilkie, has good and predictable results for power and range of motion. It requires preceding distraction to accommodate free joint transfer. In contrast to radialization, tendons of the radial side can be used to restore to extension and flexion and do not need to be transferred to the ulnar wrist border. Angulation can recur during adolescence due to uneven growth from revision surgery might be necessary at this stage. This procedure and treatment is highly demanding. Apolyzation is a good option to create a grip, even in radial dysplasia where index fingers are stiff. The thumb acts as a post against which the ulnar, better functioning digits pinch. Even if no wrist correction is performed, it has the benefit of creating this basic hand. The same is true for reconstructive procedures in minor hypoplasia of the thumb. With forearm distraction lengthening, I have myself no experience. Reported results vary greatly between 4 to 6 to 10 centimeters. In arms that lack around 10 to 15 centimeters of their 25 to 30 normal, the first is a minor change, whereas the later would be a great enhancement. I strongly advise to tailor your treatment to your setting. Recurrence rate of wrist angulation are high in secondary operations frequent. If children are operated late, temporary or definitive arthrodesis is a possible option to get the wrist straight. You will get satisfactory results with every technique, as you will be able to sustainably correct the angulation if you follow your patients over 15 years. So be smart when deciding on your treatment plan. Thank you for your attention.
Thank you, Alex, for your smart presentation in a really a difficult topic. Actually, many of us are not comfortable doing these cases in our setup. And if there is any question, we'll discuss in the later part of this session. At this moment, it is my privilege and pleasure to introduce Dr. Raja Shobapati. Actually, he has already been introduced in his previous talk, but his name is enough to describe about himself. And he is already very well known for his hand surgery courses and excellent academic interests. And already he has trained a good number of surgeons from different parts of the world in the Gonga Hospital. And we'll now discussing on the seam brachydactyly. There are different ways of reconstruction of seam brachydactyly cases. But Raja Shobapati will focus on the non-microsurgical techniques of the seam brachydactyly reconstruction. So Raja, please start your presentation.
Yeah. Thank you, Tanvir. You able to hear me? Yeah. So, so the problem in seam brachydactyly is...
Raja, your talk is not up. You have to...
Sorry?
Your slideshow is not up.
I'm seeing... right, okay, I'll just do it again.
Yes.
You see now?
Yes.
Yeah. So in seam brachydactyly, if you ask me, well, what's the problem? I think they are all short fingers, and they may have redundant skin, and then they are floppy. So when you try to hold it or something, the child doesn't have enough of strength. I think that's the time. That's the real problem. So what are the options available? There are two options available, which are common. One is free toe phalangeal transfer, which I'll talk. And Simon will talk about the microsurgical free toe transfer. I think both of them got certain indications, and in certain things, each of them fall very well. So what exactly we mean by free toe phalangeal transfer is for the same child which I showed floppy fingers. We take toes, toe phalanges, and we usually put them in. I think we have put it in all the 5 fingers we have put it in. And the important thing is we need to see that they retain the growth potential. I think that's the key. And we'll see how they do it. So it's the same child, which is totally floppy fingers. Is a picture that's taken about 6 to 7 months after the surgery. And after that, you find they're able to hold it. I think they hold it and throw it. So I think that's the key as to what we are trying to achieve. So how do we do that? The next is the technique. And it's a non-vascularized. So it should be possible to do in most of the places. The key thing is that you must have an extraperiosteal harvest of the proximal phalanx. And there is a donor state mobility. To a certain extent, we can do it by, we can obviate it by suturing the flexor to the extended ascendens. We'll come to that. And we also have only one case with an iliac bone rash. We will see that also. So how do we harvest? We always choose from the 3rd or 4th or 5th row. Usually, if you want 2, I think we take the 3rd and the 4th row, because we don't take from the 2nd toe, because keeping the 2nd toe still keeps the option of the microvascular toe transfer possible. Okay. The toe phalanx is to be dissected extra-periosteally, and you must keep some amount of capsular attachment both at the top and the bottom. I think mostly at the bottom must be there. And when you take this, you must be careful because you're going extra-periosteally. You must not cut off the flexor tendon. I think I cut it once. So I think that's a problem now which we need to take care. And that's the way they come up. The reason for telling some amount of soft tissue, keep it here, is that you will have a flat head of the metacarpal over here. And you need to have some soft tissues created, and then you need to attach them. So that's the reason we say do this. You could pass a K-wire, because you're going to pass a K-wire, and don't make the incision on the top tip. You must have a skin so that the K-wire has to pass not through the incision. I think it has to pass through the skin. I think that's important. Sometimes I will not put in a K-wire, but then we do this. If you are able to do for all the 4 sides, so what I do is take from 4 things like this and then put it in, and then put all the things that are inside. The key to do this is you must have a good pocket. I think that's very important. If you don't have a good pocket, you don't get a good result. I think that's important. If you don't have a good pocket, what happens? 2 problems happen. One is the skin necrosis can happen. The tight pocket does not allow this bone to grow. I think so. That's the key. So here you are putting this thing to 2 fingers, and then you allow it to grow. So this is the important consideration, as I said. And if you don't have a good amount of laxity, the wound does not heal primarily. I think if it doesn't heal primarily, it's gone. So I think it must heal primarily. So some few illustrated cases, you find all 5 fingers, I think all are floppy. There's the X-ray. You only have the metacarpals. You don't have any of the phalanges. So what we did was we took proximal phalanges from 2 from one foot and the 3 from the other foot, all 5 put on at the same time. I think all the 5 put on at the same time. That's the picture. It's taken about 4.5 years after this. This is the child who has got this. And that's the X-ray. I think that's the take in the long-term X-ray for 4.5 years. The child, I think now is a little bit way older now. I think it's one of the pictures that he sent recently. He asked him to send a picture. So he's able to use it. See, suppose you have not had these, I think what will really difficult is that you will, and they all have to stay on top. I think they have to stay on top of it. I think that's the key to do this. So another illustrated case, you find again these things are floppy. So you need to understand this is possible if only there's redundant skin. If there's no redundant skin, there's no surgery, no non-microsurgical transfer. So again, you put like this, and it's a functional outcome. And I've seen this child see he's able to take, I think, bigger things. I think he's able to take hold it. I think this will not be possible if you don't have this thing. So that's the picture that you get, and then you see that this again is the long-term follow-up. It's around 6 years. I think these are the ones now which you have put. I think these are the ones now which you have put. The epiphysis now is still open. So in the illustrated case 3, here you find there's only one metacarpal here and nothing over here. So what we did was, in a hand, you need to have an ulnar post and you need to have a radial post. So here for the ulnar post, we thought now we'll put in a phalanx. So we put in a phalanx. So we came back after some time, and then for the other side, now we put in a toe transfer. So here, so having this as a non-microsurgical option can also be combined with a microsurgical option in this patient. So now this is the picture long term is taken. So if we had put in 2 toes on both sides, it would have been much better. Now we discussed this option at the very beginning. The father didn't agree. So but then you find this has really helped. See, that's the picture. It's a long-term picture. It's 11 years after the TOEFL. I think it's good length, but it is turned down. It's end-on view. And 9 years after toe transfer. It's 9 years after toe transfer. So you see how she's doing. You will find when she is holding bigger things, she'll use the toe, and this both of it will hold. And she grips it. So I think she uses that. But then if you want to pinch, I think she uses it with the palm. I think that's what happened. But then they know how to handle things. They are not really having. And this is the worst toe. This is the worst result that we have. So I thought I should put it. So here you have a toe transfer. So that's the toe, that's where we had toe transfer, and this is the one where we had a proximal phalangeal bone graft. So can we say donor sites better? So that's the point. I think Simon K could be the better person to answer this for this child. So we are trying to put in a, and then we put in a iliac crest bone graft input. Normally what we do is after taking extra periosteal harvest, we suture the flexor tendon to the extensor tendon, so there is some gap, doesn't really collapse. But then in that interval, we just put an iliac crest bone graft taken. This is one of the long, I think there's a picture that was taken after a year. So that is the bone graft that we have put. And if you see this toe, I think it looks a little better. I think it does definitely look better. But then we have shown this photograph and another photograph to a lot of all our patients and said, it's okay, because they see the other children, we have the videos of running, walking, and all that. So only one child we have been able to do this. So that's the boy whom we have put in this bone graft. So you see the pinch part of it, the stability part of it. You take a ball, obviously picking. So he is able to pick it up. I think that's because of the stability that has been got. But this is a 9 years follow-up of this child. So the 10-year follow-up radiographs of this patient, I think that's where we have put this. And this is pointing out towards the thumb part of it, so he's able to do well. So here again, another patient, so we can put this in, and they all survive, and they are able to use it well. So you'll see that this child, I think it's a long video. I think here you'll find the later part. For finer activities, they're trying to push that into a small hole. I think she's able to use it. She's able to hold this. So the results, if you ask, the few questions that usually people ask. We did a study of about 42 free phalangeal grafts, which we have put. And some of them we had a very long-term for the demographics we have for everybody. But then we could have some long-term results. We call them in and then ask them. So I'll answer all these questions. The first question is, do these phalangeal grafts grow? Yes. So what we have found is that a study that we did, facial patterns were 72% over a follow-up period of all the patients that we have taken together. And how much do they grow? I think that's low is that the mean growth is 4 millimeters. And you will find that the growth is different. I think you'll find if you have done this surgery before 18 months, and 18 months to 4 years, I think we did them for later also. Some of them got good results. But then you'll find that the growth rate is always better if you do it early. So why did we take 18 months? Is because we just analyzed the other papers which have been done before, and then all of them had taken 18 months. So we also took 18 months. I personally feel I think we could even take it much earlier. Number 3 point is that, third point is, does the age at operation matter? Yes. We found that if you do it early, I think lesser than 18 months, the rate of open physis is higher. I think if you do it later, I think some of them remain open, but then the growth pattern, I think, is much different. And so there is a case, for doing this early. So do they grow as much as their contralateral toe counterpart? I think that also we analyzed. We will be able to get 20 fellows to do this. 20 transfers were compared to the appropriate contralateral toe phalanx, and the growth was found to be 75% of the normal. So they do grow, but they do not grow as much as the rest. And if you analyze in places where they are not grown, I find where we have put in 1 or 2 passes. I think as Simon said, if anytime you put KY, it has to be a single pass. One shot, it has to be there, one. And secondly, you cannot have tight closures. I think there, it again causes a vascularity problem. And are these digits sensate and functional? I think there's no problem with sensation. So they're all got sensation. And some of the patients we took where the pinch was essentially because of the phalanx. I think that area we found, and they found they do have a pinch that is a lot good. And do they move? I think they do move. I think they do move. And because we attach whatever the side tissue tendons are there in the other side, and we attach it with capsular, and suturing is very important. And the next question is, so you see, all of them have got functional activities. You will find all of them are doing it much better. This is a girl with the toe transfer. and he's a boy with picking up small things. They can even pick up small things with what we have done, and they use it for differing widths. They are able to hold it for differing. So it definitely enhances their functional capability. And are these children and parents satisfied? We use this validated outcome measures, and we found if you use the aesthetic part of the MHQ, children always they gave higher scores than parents. I think parents always didn't score them well, but then children did well. And children who are evaluated possibly had high scores in all domains except activity. However, these children had a higher happiness scores than the normal population. You will find that all the scores that we make, children score better. They all know children scored them better than what the parents they thought that the children were having. So we think this is one of the good operations to have. So I will conclude by telling that we think it's a good procedure for symptomatic management where there is a redundant soft tissue. I think that's very important, and you should not do it early. And even if you think you're going to do a toe transfer, I think it's greatly lost, because if you have to do this, we do it very early. I think in toe transfer we do it a little bit later. So that's it. And then none of the cases were done. We had done 42, and none of them had any total resorption. I think no case had a total resorption. There was always something, and which the children really used it. And all these children use these digits more than what the objective measurements will show. If you take up if you really see them, how they use it is, and it is very technically, it's very demanding. I think you must have most important things. You must have a good pocket of soft tissue to put the graft without tension, and you could use it as a part of it as a treatment strategy where you could also, as Simon is going to talk, where you could also use with toe transfer for one side. And donor side mobility, it is seen. We can't say it is not seen. It is seen, and it is collapsed. But in our children, I think probably it's a cultural variation. But I think probably all of them evaluated it on the basis of what they gained. I think it's a bartering. I think you just bartered for a bigger cost. So none of them, it really, they said it really mattered. But all of them, if you say, ask them, does it seen? All of them say yes. That is quite obvious. And it appears to be lesser iliac bone graft is used, but only one case we are able to use it. Probably the concern of operating at two sites made our parents not accept for it. And functional and psychosocial outcome studies reveal a very, very good outcome. So thank you very much for this option.
And perform this procedure. Very quickly, because we don't have much time left for discussion, so we will proceed then to the complex cases discussion. Only one question to both Raja and Simon about the management of the donor site in the foot after free phalangeal transfer, non-vascularized. Simon and Gronia published on this topic in the past using the iliac crest bone graft, and they see that Raj has done one case with success. So I would like to hear from both of you what you think about it.
Shall I go first, Raja? Well, Gronia was my registrar when we thought, I used to do a lot of free phalangeal transfers, and I hated the donor site. And we'd had a lot of discussion with other people in Louisville and in Hamburg about this. And we decided to do a cylindrical graft from the apophysis of the iliac crest. There's no doubt that helped the donor site, but still the donor sites can be really bad. And I finally decided to stop doing it because I didn't feel the growth that we got was worth the result in the foot. And a little bit of me said, well, why don't we put the apophyseal graft in the hand and cut out the middleman? You know, that seemed more logical, but actually we found the function we gained compared with toe transfers was so small that the deficit in the foot was scarcely worth it. I'll just say one thing, Raja, that's a top tip, which I can't justify scientifically because I've only done it in a few cases. But when you're doing a toe transfer, rather than discard the metatarsal, we've trimmed it down to fit as a free phalangeal transfer and kept the epiphyseal plate distally. And in the ones we've done at a year or around a year, it has grown. So, and we've always stabilized it. We haven't gone for movement because there's no joint. So we've stabilized it. And I think one of the things that helps these grow is stability. And we know that in other parts of the skeleton. And the presence of a loosened epiphyseal plate doesn't mean it's growing.
Thank you very much. Raja, do you have any other comments? We cannot hear you, I'm sorry. I think you're muted still, yeah.
The donor site is a real problem. And I showed you the worst donor site we had. And sometimes when you do it, the 5 phalanges, so they almost become normal. So the three of them, but you only have to. Actually, we didn't really stop talking about this. But I thought we'll leave it for 10 years. So we'll have a long time follow-up. So after about 10 years, now I'm convinced what we did 10 years back were okay, and we got all these children back, and then saw them. All of them are using the fingers, which otherwise would not. So I'm also a lover of toe transfer. So toe transfer will definitely achieve better results, no doubt about it. No, I would say toe transfer will achieve better results, but there are only very few people who can do toe transfers in children. So for that reason, I think this is quite a viable option. That's my point.
Yeah, there is we have an international public here, and absolutely there are, of course, centers when there is no possibility to perform microsurgery, but definitely toe transfer is the golden standard. I think it's your turn again, and thank you so much everyone for attending this session.
Thank you. So we are running behind, but I see there are still quite a good number of participants, so we will carry on. Please feel free to leave as you if you need to, any of the participants, but we will carry on with the complex cases because this will be recorded. So these cases have been sent in from different people, different countries, and I've let some of the faculties in some of these cases because of the previous feedback, but some of them they haven't seen it. Some of them they haven't seen it. So so that it will be more exciting. So first case, we're going to look at a thumb duplication case. So this is the case from Kemi from Nigeria. I think previously she mentioned that she would like to ask what the panel would do. So I'm just going to quickly ask Drew. Drew, what will you do? So the question is, how would you approach this surgically? Which thumb would you keep? What are your pitfalls and pearls?
Thanks, Wee. Looking at this thumb, I think this is one of those which I would certainly do an on-top-plasty. If you look at the more radial of the two, that's a much better metacarpal, but perhaps the more ulnar one has a better P2, P1, and I think this is one I would certainly do an on-top-plasty for this one. I think you're going to get a much better. I'd want to see how she uses it as well. I suspect that proximal or radial thumb is going to be the one that she actually uses functionally. I think she's old enough that she'll probably be using it for quite a bit of her function anyway. And I suspect that's the one that's going to be moving. And the ulnar one has got no base. No metacarpal base, and certainly won't have a CMC joint. So, okay. So that would, in my hands, would be the ideal one. I think Tonkin calls it an acral transposition or something. I don't quite know why, but anyway, that's an on-top-plasty for me, that one.
Thank you. Raja, what are your pitfalls and pearls, and what level would you do the on-top-plasty?
I think I showed a similar case when I do this. So what I'll just take off the top part only. I think more than what level, I will first take off the redundant part in the ulnar component and try to find where it goes. Okay, and then divide the radial part, because suddenly you cut it off and then they don't go or something. It's a problem. So I think that will be the part. And you will find we need to take the ulnar component. I have seen the older children like this. What happens is only the radial part moves. This ulnar part just comes in between. When they try to hold this ulnar part here and there, now and then will come in between. So they are not allowed to learn. I think that will be the part. So first dismember the ulnar component, see where it goes comfortably, then make the incisions in the radial component.
Sort of metacarpal area. Okay. Yeah. So that was a bit of a warm up. We now move on to a cleft hand. So Scott, This is a 1-year-old girl, no obvious syndromic features. We're just gonna look at her right cleft hand.
Right, so, I'm sorry. So if you...
Yep, the first web appears adequate in this one, so we will be interested to know, would you treat this hand? Would you do anything, and what would be your surgical plan?
So I agree with you. We would not address the thumb index web space. It looks adequate. We would try to address the alignment of that combined super digit, between the long finger and the ring finger. And we probably try and do it by correcting the bony anatomy. We would not take those fingers apart. I don't think they would work well separated. I think they'd be too unstable. So we keep them together, but we try to better align them as the child got older.
So Scott, what would you do to the, I'm just going down the sequence here. What would you do to the proximal phalanx?
That will likely need some form of closing wedge to bring in a better alignment.
So you would keep it as it is in terms of the width, or you would do a longitudinal osteotomy split here?
Yeah, I would look carefully at the MCP joint. And if the MCP joint functioned in a unit, I'd keep it as a unit.
Okay. What would you do to the third metacarpal?
Nothing.
You leave it as it is?
Leave it as is.
Okay. Simon, what would you do for this?
I'd really like to have commented on the previous case, actually.
Oh, okay.
Just quickly go back for a moment. I just want to say one thing about the previous case. So, this. So when you're talking about on-top plasters or acral transfers, whatever you want to call them, the point is you're looking at this radiograph and you're not looking at the soft tissues of this thumb. So I would want to see how that child is functioning. I agree with Roger about that entirely. And then I suspect that although there is a skeleton in the radial element and in the ulnar, and the radial looks as if it's got a broad base and might be stable and the ulnar doesn't, neither of them is likely to have good flexor extensor apparatuses. And so I wouldn't rule out the possibility of a policization in this case. That's the thing I want to say. Now let's go to the next case.
Okay.
You have to see it work. You have to see what's there.
Absolutely. Thank you. Okay, so back to this case. Any other opinions?
The only thing that, I mean, I'm not sure you have to do anything to this hand.
Okay.
And there's certainly no hurry to do it. But I think you're trying to tempt us into saying the third ray is redundant. And it may or may not be, but it depends very much upon, there are no creases on the mega digit, which makes me worried. The third ray may be redundant, but you have to understand the architecture of the composite PIP joint there. That may be very difficult to reconstruct if you do separate it. And functionally, that'll be a good hand, whatever you do to it.
Okay. Jill, what are your thoughts, Jill?
I would separate it. I would probably remove most of the third metacarpal, and I would reassess that first web, which looks good on the left-hand picture, but I'm not sure. So I probably would move the skin across. I think there is a slightly deeper cleft between the index and the mega digit, and I probably would correct that. Obviously, what I'd want to do, as Simon says, I want to assess the function. But on the left-hand picture, it looks like there's probably a PIP bend in some form, whether it's a permanent flexion deformity or what.
Okay. So I think that's interesting, varying views. If you're going to do something, so this is one option. I mean, there are various options. I do not think this is one for a snow littler flap. And this, I think, is what we're kind of talking about. Let's move on to the next case. This is a case from Bangladesh. So a 1-year-old boy, no obvious syndromic features, unilateral right cleft hand. And you can see this is a much serious lack of first web space. It's a syndactyly between the thumb and index finger, and synostosis between the ring and little, and a deep cleft. So this is another view. Scott, can we start with you first?
So this one is amenable to some type of modified snow littler, where you would close that cleft and open up the thumb index. It's hard to tell where those metacarpals are going. Like, where's that proximal phalanx going on the index, or is that a mega digit? I really can't tell, but we would operate on this finger with some type of snow littlerish operation.
Okay. Any other views? Raja, what do you think?
100% operate on this because, as Scott said, modified some sort of stone litter will be good, and you'll find this proximal phalanx, and this will have a joint with this. So what I will do, this has to be removed, and we will increase the web space. To increase the web space, just leave a sliver of it. I won't open the joint because this will be going there. Rest of the phalanx we open up and then split up and put in the web in it. I think we'll operate on this.
Okay. Right, I'm just going to move on to radioplasia, thumb hyperplasia, because this is quite a controversial topic. So this is a patient from Bangladesh, a 22-day-old boy, imperforate anus, club foot, left radioplasia, very recent presentation, no thumb. So just for educational discussion, what syndromes do you need to be aware of? Jill, what do you think?
Well, if they've got no thumb, it's not going to be TAR. So you're thinking, you are thinking Fanconi's, but their head circumference looks good, but you're always worried about that. There are a myriad of symptoms, a myriad of signs. So it could be vactral, whole orum. I mean, I'd want, hopefully, even in Bangladesh, they better get somebody to do an ultrasound of the heart to check the heart out, and look at the child otherwise. But with, you are wondering what else could they have wrong with them, and particularly with that, it sounds like vactral is the most likely.
Okay.
Needs a renal and a renal ultrasound and a echo as a bare minimum.
Okay. Simon, would you treat this child? What would be your management now? What would be your management later?
This child now is very much along the lines Jill said, except that I'm not sure, you have to adapt your behavior for your environment. I'm not sure how much help it is to diagnose the propensity for Fanconi's with chromosomal fragility this early if you don't have access to a rescue twin or a savior sibling or any of the other things that we strive for. In terms of heart and so, yeah, of course you want to look for vactral vata. I suspect in Bangladesh the cardiology expertise is very good, and a lot of the ability to listen to hearts and things is vestigial here in the West. So I suspect it's very good there, and they would be able to screen this child fairly easily. Renal function's all right. I don't care how many kidneys they've got. And then come to the hand, and the issue in the hand is far too early to tell is the answer. It looks as if it's a very deviated wrist. We haven't seen a radiograph, but I'm just wondering if they have a flexed elbow as well, a fixed flexion or an elbow contracture. And if they do, you want to be very careful about correcting wrist and hand if you can't correct the elbow. And sometimes this will be a very functional deformity, malformation. So I wouldn't do anything at this stage apart from hand them over to the pediatrician and say, help yourselves. And then I'd like to see them again in a couple of months.
Thank you. Scott, what would you do now for the wrist especially?
Yeah, we would just start with some simple stretching actually. And what Simon said before has been our experience that in these to develop a ulnar prehension, we no longer apologize. So I don't know. And it's hard to tell how stiff the radial side is, but we would go slow.
Okay, so I think that's the discussion I want to carry on about how the management of radioplasia is slowly changing over the world. This is a 20-year-old man with bilateral radioplasia and thumbs, currently employed and no issues with activities of daily living. Would any of you treat this patient?
No. No way.
Him surgically. If he were in our, okay, sorry, we don't just cut people. So if he were in our clinic in Leeds, and I realize there's a big difference with Cambodia, then I would explore why somebody with a birth defect is presenting at 20 for treatment. And clearly there are some issues there that we would explore with the clinical psychology team. But surgically, no, I wouldn't do anything.
Okay. Scott, would you do anything?
No, not at all.
Okay.
I'd want to know why he came to see you, just like Simon.
Absolutely.
Whether it was even to do with this radial club hand.
Okay. Right. Next one. This is a 4-year-old boy with a right radial aplasia and left thumb hyperplasia, 3B or 3C, depending on your classification. Would you treat this patient? And what would you do? I'm talking just surgically here. So it's obviously an ulnar prehension on his right and an index middle finger prehension on his left.
So his brain thinks that his left index finger is a thumb, and you can help him along there. You can either do, depends on your resources and your confidence. If you're confident about policization and that you're not going to just kill the index finger, which would be a bad outcome, then he will do very well from a policization. I wouldn't do anything on the right hand because he's 4, he's got ulnar prehension. His brain is never going to think his index is a thumb. And if you take away his radial, I don't like the term radial club hand, by the way, but if you take away his radial deviation, then, and I'm sorry, I should explain why I don't like that. We've got away from saying lobster claw and things like that. And I think we can get away from the sort of, the slightly pejorative, this is a club foot, this is a club hand. But that's just my feeling. Look how well he functions with the ulnar. So I think the question is whether the parents trust you and you trust yourself to do a policization on a finger that is becoming a thumb as you watch it.
Okay.
That's how I feel about it.
Scott, what would you do? Anything different?
No, I agree. Policization on the left and nothing on the right.
Nothing on the right. Jill?
I do a policization if the family would agree on the left. I think it would do very well. On the right, I would discuss whether they wanted risk correction. I certainly would not consider a policization on that side because I don't think that they would ever use it, really. And I agree with Simon that actually the child's very functional. The child doesn't have to have anything done. If we were to do risk correction with, and I would do it with a distractor at 4 is quite a good age in terms of the child complying, eminently bribable.
Okay, Alex, would you do anything to the right wrist?
So the thing is that actually my experience is that most of these patients, once they get adult, they like to have the hand in front of their forearm. It's just because of their appearance. Question is, what do we do to their function? But I would say I would go with Jill and try to put on a fixator and distractor.
So I think we can see that radial aplasia is still an area where there are differing views. Nicholas, are you there? Nicholas, what would you do if in Malawi for this?
I think what I would do is I discuss it with the family. But what I'd be looking at is the function, and looking at it, it seems to be functioning very well. Because one of the things that we have in Malawi is that we do not have enough, physiotherapists. It's like the surgeon is everything in a way. So you've got to be very careful that you do not take away the function of the patient. So we'll look at first and foremost the function before you look at the appearance.
Okay.
But definitely in this culture, people would like, as Alex has said, the hand to be like in a straight position, But basically, I don't think I would do much in this environment.
Okay, thank you. Right, I think the debate will continue. So, quick question on amniotic band, 18-month-old right acrosyndactyly, and on the left hand, sort of quite typical constriction bands of the middle and ring fingers. Jill, very quickly, your management plan?
Well, I can release that. The patient could have Simon was talking earlier about toe transfer. The child could have a toe transfer if need be, or I could do absolutely nothing if need be. They look pretty good. They're going to be a very functional one. Oh, sorry, I'm looking at the top right. It's still got a syndactyly. I'd release that. But otherwise, it's pretty good. I might improve the left middle, but it's still going to be a pointy one. It's the sort of one that Simon would probably do a toe transfer on to make it look prettier and give a little bit more power grip.
Simon, is that true? You will do a toe transfer on this? Simon, you're muted. Sorry.
Sorry, Simon, if I'm putting words in your mouth, but I don't think it's an unreasonable thing to do.
Simon, you're muted. Yep. Okay.
Sorry. I'm not muted, actually. I don't know. Oh, no, I'm not muted. Sorry.
No, we can hear you now, Simon.
Can you hear me now?
Yes,
yeah,
we can.
Sure. Yeah. Speak, please.
Guys, my headphones had run out of oomph. No, I wouldn't do anything with this, Jill. This is surgery on demand. The child will grow up, and when it makes a request, it can be discussed. But I can't see a functional issue if they have. And I actually wouldn't release the syndactyly either. I can't see a great benefit in that. I presume that top right picture is just postural. It's not actually deviated.
No, I think that was the syndactyly I said I'd release. I think it's a syndactyly there.
Okay. You think it's got an acrosyndactyly?
Yeah, I do.
Okay. In that case, I would.
Okay, I'm not going to. I'm just to throw this into the span. This is a case from Tanvir, which is change of management. But I do want to go to this case. This is an 18-year-old girl, no obvious facial features, severe constriction band. She presented when she was 18 with a radial nerve palsy.
Yes, I'm not surprised.
Raja, what would you do for this, Raja?
So I don't think we can improve her functionally. So, but then now when I hear it, so the looks, and I will correct the constriction band.
You release the constriction band.
Yeah, and for such people who have been for long, and I'll do it in 2 stages. I always used to do it in 1 stage. For one time, one patient, I had a pale hand for about a few hours, and I got so frightened. So from then on, I always do 1/2. Okay, but then when you do Zs, you need to do really big Zs. Many times the Zs become a problem. They bad this thing because people trying to do small Zs. You really need to do big Zs, and then you need to really take off the constriction things, all the stuff in the base. I think those are the 2 important points which you need to do it.
Okay, thank you. Jill?
And in answer to that question there, would think to change if released earlier. I don't believe they would. I've explored a number of constriction bands in the upper arm, very young, with usually radial, but occasionally ulnar nerve pauses, and I haven't found a nerve.
Would you
I haven't found a pinch nerve. I haven't found a nerve.
Okay, so there's nothing to graft proximally and distally.
Yeah. Actually, in one case, a patient was there, a high constriction band, and the biceps were also not there. The whole hand was flail. So what we did was release the constriction band. After that, use a facial atta to above and below, and then he had a flexion came off. And I think it very nicely came. And there were some nerve elements were there like that. So I did put a graft, but the problem was the patient had another constriction going down. So I just is the visual thinking that it came up to that level and then stopped. So the nerve part of it we are not sure, but then this is a good point in the sense that they don't flex the elbow also. So if they have a constriction in the mid arm, that means that proximally the bicep is okay, and from there you can connect it, and we had a good flexion.
And that's quite right, Roger, because you can see there's no elbow flexor crease here.
Yes. So if you do it very early, you can get elbow flexion. We got a very nice elbow flexion in these patients.
I think we're just going to go to the last case. This was sent in from a professor from India. I don't know how old the boy is. There are no x-rays. I'm just going to end with this case just to get a feel of what the panel thinks. The question is suggest the appropriate diagnosis for this patient and the appropriate plan of management. This seems to me like some form of deep cleft of the entire upper limb.
And lower limb.
And lower limb, yes.
Yeah. So this is a split and split fit complex, that type of case. So we had on patients like this, but not surely. So they all, it's very difficult to walk. I think they had to walk like this. And we had a father who was strapping this back, and both of them, and then putting a prosthesis, that's working. So we did a elbow prosthesis, and in his hand, He had only one half of it we had, and then what we did was we microsurgically transferred the feet to the hand. So one part of it is moving. So I think recently we published in PRS Global Open where exactly this type of problem. But in the hand, he had a better, only one ray was found, and that ray was straight, and he had some tissues, in the forearm. So amputation for better process, and use that as a microsurgically foot transfer to the hand.
Okay. Any other comments?
Otherwise leave him.
Okay, I think that is our the end of our complex case. We've come to the end of the webinar. I just want to say a couple of housekeeping things. Can everybody see my screen? So I want to thank everyone behind the scenes, first of all, because they're often forgotten, especially Emma Brighton, who has been running this webinar for us, and all the trainees who have been involved behind the scenes. I want to thank all of the speakers and moderators. This has been a two-part symposium, and there has been a lot of organization that's gone into it, and I'm indebted to every single speaker and moderator for helping out with this. And thank you to all of you who participated with this.
Thank you, Wei.
I realize I've not managed to share the screen, have I?
Yeah, no.
Yes, so thank you to all of you who participated. Yes, so just to say that feedback forms will be sent to you very, very soon. Certificates will also be sent to you. This webinar is recorded, and it will be on the BFIRST and BSSH website. If you haven't already done so, please download the OMT reference app. And we hope you really enjoy the session. Thank you very much for staying until the very, very end. So for all the speakers and moderators here, please remember to attend the pros meeting briefing in the other with using the other Zoom link immediately after this. Thank you very much to everyone who's attended. Thank you. So we're going to end the webinar here. Thank you.
Bye-bye.